80 or T1? Who first
So good morning once again. We welcome you all for joining today's live webinar on overview on Omicron on oral antivirals. This webinar is organized by Department of Community Medicine, Department of Pharmacology and Central Research Lab. As all of us are aware, right now the entire world is coming to a halt because of this Omicron, the various ways you can pronounce this variant of concern is extremely important. And today we organized this webinar in collaboration between these three departments because we felt it is extremely important for us to understand the basics, how this variant of concern evolved in the middle of the pandemic, because we have been in the middle of the pandemic for the past 2 years. All of us can recollect that exactly 2 years back, we started this experience of living with the virus, coronavirus, COVID-19. And today, after nearly completing 2 years, we are still thinking of lockdowns. Exactly today morning, the global scenario is extremely apprehensive because the global capital such as United Kingdom is identified as extremely high risk country. Germany has identified people coming from United Kingdom are at risk of transmitting this Omicron variant. And today's live webinar titled Overview on Omicron and Oral Antiretrovirals is extremely important step taken by all the three departments, Community Medicine, Pharmacology and Central Research Lab, bringing the latest updates, scientific advances as well as public health surveillance measures undertaken in the midst of this evolution of variant of concern to the entire audience, so that all of us will be taking appropriate measures to address this variant emerging in the middle of populations at risk and vulnerable populations in nursing homes, schools and orphanages, as well as travelers, because this is the vacation season. All of us are looking forward to spend time with family towards the end of the year, whether it is Christmas, New Year celebrations, or in Tamil Nadu, the coming Pongal celebrations. So towards this kind of dynamic, we are also experiencing the entire globe once again looking towards announcements of.
So what is the hand hygiene? Then use of personal protective equipment, then disposal of staff, then environmental cleaning,
Restrictions and also certain other restrictions regarding our movements and gatherings because of parties we are planning, get-together parties, Christmas parties, get-togethers. With all this context, today we are extremely happy that we can bring you all together for this academic learning event. And I once again welcome you on behalf of all the three departments, Department of Community Medicine, Department of Pharmacology, and Central Research Lab of Tagore Medical College and Hospital. We welcome you all once again for joining this webinar, Overview on Omicron and Oral Antivirals. Today, as you have seen the invitation, we have our guest of honor, Dr. K. Kulandaswamy, former Director of Public Health, Government of Tamil Nadu. Sir will be joining us around 10 o'clock, and we are extremely delighted Sir has accepted our kind request in spite of his busiest schedule as a public health administrator, former administrator, and currently he's acting as a consultant advisory member for the Government of Tamil Nadu, how to tackle this pandemic variant of concern. So Sir will be talking to us very soon around 10 o'clock and sharing all the insights, real-time updates, how Tamil Nadu is bracing to tackle this variant of concern, Omicron, in Tamil Nadu as well as India. So we look forward to that session. Apart from that, we have lined up very interesting mix of sessions. As you have seen the program of agenda, after Sir's session, we have our own in-house expert virologist, Dr. Kannan Sir, officer in charge of Central Research Lab, going to talk to us about the evolution of variants of COVID-19, especially in the context of Omicron. How did it emerge? In this last 2 years, we have seen the maximum toll taken by Delta variant. Still in US, Delta is raging. It has not taken a back step. It is competing with emergence of Omicron. So Sir will be enlightening us about the variants of COVID-19. So we look forward to Sir's session too, followed by which I'll be talking about Omicron in India. What is the status update? All of you might be much more aware than me, looking into the various social media feeds and alerts coming in real time, state by state updates, what is happening in Tamil Nadu, Puducherry, Andhra Pradesh, Kerala, Maharashtra, because every state is logging in new cases of Omicron variants being detected in the patients who are either traveling inside or have some exposure to the travelers who have come inside. So I will be sharing my presentation very soon. After that, my young colleague, Dr. Vikram, the Assistant Professor in the Department of Community Medicine, will be talking about public health surveillance tools. All of us know how public health measures have effectively tackled the containment of pandemic. From the beginning of pandemic in 2019, WHO has been leading along with CDC Atlanta, how public health surveillance tools, including lockdowns, travel surveillance at airports, and house-to-house surveillance, mass vaccination campaigns, all these public health surveillance measures which were undertaken by federal governments, state governments, local governments, aided by grassroots level health workers, medical colleges like ours, all of us have pitched in our efforts to address this pandemic at individual level, institutional level, community level, country level, at global level. So the pandemic is not just the virus spreading. The other way, all of our efforts have been cumulatively targeted to address this pandemic. So Dr. Vikram will be addressing in his session what are the public health surveillance tools, and he will also focus, especially coming from the Department of Community Medicine, how to protect yourself and others. So we look forward to his session, and in between we'll take a small lunch break, after which Professor HOD of the Department of Pharmacology, Dr. Geeta, she will be leading one of the most critical angle of today's webinar, oral antivirals. If vaccine technology is one of the path-breaking standout insight in the emergence of the pandemic, the other dimension of addressing the virus or variants of concern is pharmaceuticals, therapeutics. And all of us know clinical trials are happening at breathtaking pace. And today's session, titled Omicron and Oral Antivirals Overview by Dr. Geeta, is going to spotlight what are the various drug trials happening globally. And I'm very much eager to listen to her session because interesting work has been done by Pfizer. Every day I'm listening to the new data submitted for FDA, for approvals because we need vaccines and therapeutics go hand in hand to address this pandemic. Apart from this, I have one more session talking about universal health coverage, COVID-19 vaccine and Omicron. All of us are critically aware what is the importance of prevention in a pandemic scenario. Prevention is better than cure. No one will have any doubts about this age-old saying. So when we talk about vaccines, all of us are aware India has reached so many people with its indigenous vaccine technologies. And we are very proud to say that India, under the leadership of Prime Minister Narendra Modi ji, has covered so many people with first dose of vaccine, and a lot of us healthcare providers have also completed our second dose of vaccine. But in today's context, with the emergence of Omicron, there are certain issues we need to be aware about. What is called as complete vaccination? What is the angle of boosting? And why it is relevant for us to look forward for boosting dosages in the next year. So all those things I'll cover in my universal health coverage, COVID-19 vaccine and Omicron. And towards the end of the webinar, my young colleague, Dr. Avinash Deepak, the tutor in the Department of Community Medicine, will do a quick summary of the webinar. What are all the items and topics we have covered for a day-long webinar, for which Tamil Nadu Medical Council has awarded 2 credit hours. And they also appointed Dr. Tamil Vanan as the observer for today's webinar. We have shared the Zoom link and the program agenda along with the invitation to Dr. Tamil Vanan, the Tamil Nadu Medical Council appointed observer, who will be joining us virtually anytime and multiple times to be a participant and observer for our webinar. Sir will be analyzing how the content of our webinar is being delivered, how the interaction with speakers as well as the audience are posing the questions in the chat box. So we request all of you, all the audience, faculty members of Tagore Medical and Dental College who are joining us, and also the colleagues with whom we have shared the link in Crescent College and otherwise, please share your thoughts, because Omicron is not a medical topic, it's a public health topic, and it is going to affect all of us. Either we need the awareness to raise the awareness in the community, we need the knowledge to prevent in this hospital, in our communities, in our families, and we are gearing forward to address this with the right evidence, the right scientific knowledge. With these few words, now I would like to request, because this is an inaugural and opening remarks, we have our in-house expert, Dr. Kannan sir, officer in charge, Central Research Lab, as well as the eminent microbiologist and virologist the Tagore Medical College and Dental College can boast of. Sir has registered many patents in the gene bank of CDC Atlanta, and sir is guide for us to do some innovative work in Central Research Lab. So I would take this opportunity to invite Dr. Kannan sir. Sir, can you join us in this small inaugural and opening remarks forum and share your thoughts when we are in the middle of this webinar, well-suited webinar which we have planned today. Today, the entire world is talking about Omicron, Omicron, oh my God. So can you share your thoughts, sir?
Yeah, we thought actually, especially in India, we thought that everything is over. We have all removed the lockdown and we started our normal life. So it's quite unfortunate that again, a variant has been reported in the name of Omicron. Actually, this Omicron they identified in South Africa doesn't mean that it originated from South Africa. Maybe it would have originated anywhere, but it was first identified in South Africa. But recently now they have started to identify it in our country, even in Tamil Nadu. They started to identify this Omicron strain. But the only thing still is that they're not able to report any casualties, any death because of this Omicron. But the only thing is that WHO has included this Omicron into the so-called variant of concern because of this one thing, that is because of high infectivity. So in future, this Omicron, we expect that it will start to spread in a very fast rate, and probably, as you said, it's going to be a public health concern. So as a microbiologist, we people are equipped with this diagnosis, because Omicron diagnosis. So many people say that because of the mutation, it may escape the diagnosis. But I strongly feel that our present kits, they detect only the gene like RBRT and link gene. So probably we not have the problem of diagnosing this Omicron strain. The only thing is to find out whether they are Omicron strain. Still, we have to evolve some kits. Right now, a kit called TAG path is being used to identify this Omicron by a phenomenon called S gene dropout. But now, yesterday we got a news that indigenous kits are being developed to identify this Omicron. Probably with the help of this early diagnosis of this Omicron, probably we can control this Omicron and hopefully we will not let it as a third wave in future.
That's a very positive news to be aware of. Because the global alarming situation is definitely ringing some concerning bells all over the world, and people are really worried that the spread of this Omicron variant, though now we are imposing lockdowns and global travel shutdowns, the variant has already crossed all the boundaries, and it's already inside. So in that context, when we talk about imposing these things, it is only going to slow down the progress of the virus or the pace of the spread, but otherwise the variant is already inside the boundaries of this worlds where they are right now imposing, and the lockdowns or the travel shutdowns are only going to slow down the progress. That is a good point we have to be aware of. And I have seen Dr. Vikram, my young colleague, also logging in. So let us get some thoughts from other speakers who joined into this inaugural session. Dr. Vikram, if you are kind enough to join. Are you there, Dr. Vikram? So before he joins and clicks his video into on mode, sir, a lot of talk is around these vaccinations too, which we will dig deep in our sessions. But all of us, at least healthcare providers, we are vaccinated, right? We all received our second dose. At least by August, most of us have completed, because after the Covishield, some of us were waiting for Covaxin, and so majority of us healthcare providers of various cadres have received our 2 shots. But the concerning thing is, yesterday I was reading, and it was the news says that only 60% of eligible population in a city like Chennai have only received the first dose. So in that context, it looks like we have some work yet to be accomplished at public health level. So Dr. Vikram has joined. So being a public health expert, I would like to invite his views. Dr. Vikram, the news coming from Tamil Nadu says 60% of eligible population in Chennai have only received first dose of the vaccines. So in the context of this, what are your views as a public health expert?
As far as this Omicron is concerned, actually they say that previous infection and also vaccination, it does not give much protection against the Omicron. But we cannot take it for granted. But the main use of these vaccines are that it prevents a serious disease and deaths. So what I recommend is that all the eligible population, especially who are first, and those who have taken first dose of vaccine, they should go for a second dose of vaccine. So the vaccination coverage has to be increased all over the state and also the whole India.
That's a very important point you have highlighted. You also highlighted a very specific term called at-risk population. Could you throw some light, like according to our public health scenario, who are the population at risk of, being more vulnerable for COVID infection?
Usually the elderly people, they are at risk of getting the COVID infection. Apart from them, those who have comorbidities like diabetes, hypertension, or heart diseases, they are also at risk of getting COVID infection. And also those people who are immunocompromised, they are also at risk of getting this infection. So these people, they have to be given priority while giving the vaccination. So they have to be vaccinated at any cost. They should not be missed out on vaccination.
Yeah. Here at this point, I would like to share with Dr. Kannan. Sir, everyday rural health training center in Kelambakam and urban health training center situated in Krompet. These are the two training centers associated with Department of Community Medicine. They undertake weekly 3 to 4 outreach camps, health camps. You are aware of that. So for the benefit of the audience, I would like to share that every day the health camps being organized by these two training centers under the guidance of Dr. Karthik and Dr. Vikram, who are in charge of the centers. When they come back and submit a summary report, it is so unfortunate to see that more than 60 to 70% of this small health camps attendants, they are unvaccinated, sir. So I'll tell you a small statistic here. The latest data, 40 people attended one camp by RHTC, that is Rural Center, out of which 29 people are unvaccinated. So this is a small cohort. 40 people attended our health camp, 29 people are unvaccinated. And when our health workers try to understand what are the reasons for vaccine hesitancy and not being vaccinated yet, after vaccines are made available to all the eligible population, the fear of the vaccine, the waiting for the vaccine, and fear of contracting vaccine related side effects. So it looks like there is a lot more work to be done in spite of making the indigenously produced lot of resource intensively driven vaccine technologies made available. The public needs to be approached in a different way so that the vaccine acceptance rates and coverage is improved. So in this context, we both are public health personnel. Sir, can we look for a fresh voice, how we can improve this vaccine acceptance among community from a virologist like you sitting in the lab? Any fresh ideas?
No, now there is no point in convincing them. Rather, now we are in a stage of forcing them. So you know very well now the government of Tamil Nadu has given an order wherever any public place you cannot enter without vaccination certificate. Say I want to go to a zoo, or I want to enter into a cinema theater or in a mall. I cannot enter without showing my fully vaccinated certificate. So government has taken the step. The only thing is still many malls, many small supermarkets, many other public places, still they have not implemented this Tamil Nadu government's order. So probably the government now it's high time that they should take a stringent step, see to that all the public places should screen for the fully vaccinated individuals before they allow them inside. And convincing point, I don't feel now it's too late. People are complacent rather than being afraid of any side effects or anything. They are just complacent because you know very well the lockdown is completely removed. At present, we don't have any way. So that the people are just complacent. I haven't seen even people wearing masks in the public. So they totally forgot about the COVID, and yes, they are leading the normal life. So only thing now the government has to take steps to force the people to get vaccinated. They have already taken steps. Even the other day when I went to the mall, they asked me to give the certificate, show the certificate. So I showed the certificate and entered into the mall. And this has to be made strict in all the public places. So this is my point of view.
Dr. Vikram, any additional thoughts other than what Sir has shared with us?
As far as the vaccine hesitancy is concerned, in our field practice area, I feel that community leaders or the religious people who are the leaders for them, they have to be involved and they should motivate the people to go for vaccination. Because in Kelambakam, what I found out was that those people, they follow a certain religion. So they have some hesitancy towards vaccination, not only vaccination, some hesitancy towards the treatment. So that's why they didn't go for any hospital or anything for taking health care. So those people, they have to be motivated and advised by the religious leaders whom they follow. So that has to be done so that vaccination coverage will increase in the field practice area.
So that's a very specific step you have highlighted, Dr. Vikram, and I hope you will take this targeted intervention forward and discuss with your team in the RHTC and enact certain measures so that we can also, bridge this gap. Because as Sir has highlighted, vaccine hesitancy is also linked with COVID pandemic fatigue. sir is linking that people are fatigued in the middle of the pandemic for 2 years. We feel like, okay, we have been living with this virus for the past 2 years. There is a fatigue in following certain COVID preventive measures such as continuous wearing of mask, practicing social distancing, and hand hygiene practices. Even in our medical school, we are seeing students not practicing. So medical students and medical faculty and medical healthcare workers should act as a role models. They should be the real champions of change. When they go to the community with their role modeling behavior, they, as you said, along with having multiple interactions with the local religious leader, community leaders, we should walk the talk. I believe we have to do that, because having a small community like Kelambakam and having this kind of vaccine gaps, I believe we have a lot of work to do going forward in January 2022, because a mathematical prediction by a scientist from Kolkata says that India is gearing up for the wave 4 of Omicron variant by February. Per day, 1 lakh to 1.5 cases are going to be hitting upon our healthcare system, and our hospitals are going to be flooded by these cases. The moment you test someone, sir has highlighted the ICMR has developed and sanctioned a bunch of indigenously developed rapid diagnostic test kits for picking up Omicron variant. So when these test kits are made available at point of care, people are going to be tested, they are going to be picked up as cases. Some of them may require hospitalizations, and similar to the last years, the hospitals may be flooded with these cases. Whether they are going to severe hospitalizations, right now the data is not supporting that. But if hospitalizations are going to be a scenario, we need to understand that hospitalizations and vaccinations are interlinked. If people are vaccinated, the severity of infection is definitely going to be less. So improving vaccination coverage is important for us as community physicians. We need to work on that. Going forward, as our department leadership will be more clearly cut and earmarked for us, as Dr. Karthik and you are the leaders of the community health centers for our department, I request you both on this forum, going forward, please design specific targeted interventions. And I'm seeing Dr. Kolandaswamy sir joining our session. We have to take this measure seriously and involve our communities in a very interactive participatory approach, address their real concerns, why there is vaccine hesitancy. As you said, there could be local players, local actors who can enhance that vaccine acceptancy, like community leaders, religious leaders. Also, if you identified the hesitant factors like either religion or mistrust or some side effects or whatever misinformation related to vaccine, if we address them specifically, trusted, authentic information provided by healthcare providers will go a long way in removing all these gaps in their information. And if we are in the field walking the talk, removing these barriers for vaccine acceptancy, I think the vaccine coverage will improve. And also the latest Tamil Nadu government data also supports that. With the emergence of the variant of concern, the vaccination rates are improving, and the government of Tamil Nadu, along with Kanchipuram district government, they are organizing mega vaccination camps and drives. So we can contribute to all those initiatives taken by the government from our hospital, from our department, if we are in the field, walking the talk, along with the care providers, along with the community leaders, along with the beneficiaries, if we are in the field, addressing the real gaps, I think it will improve the vaccination coverage. And we are extremely delighted to have Dr. Kolandaswamy sir joining us in today's webinar. Sir, we are extremely delighted and thankful for you for accepting our request. The Department of Community Medicine and Department of Pharmacology and Department of Central Research Laboratory, we collectively welcome you, sir, for this webinar. Thank you so much for accepting our invitation. And Karan sir, Dr. Kolandaswamy sir is here for our webinar. So we were just discussing before your session in the inaugural remarks, what is our scenario, as we would like to quickly bring you to update. The Department of Community Medicine has two community centers. One is Rural Health and Training Center. Dr. Karthik, are you there? Please join and please switch on your video, sir. Dr. Karthik, our associate professor in the department, is in charge of Rural Health Training Center situated in Kelambakam, sir. It takes care of 30,000 outreach population. And Dr. Vikram, who is our assistant professor, he is in charge of Urban Health Training Center, which is situated in Crompet opposite MIT campus. So together, cumulatively, we serve around 50 to 60,000 population, both rural, semi-urban and urban populations. And the Tagore Medical College is over a decade. We are serving our population in this entire area of Kelambakam, Kolapakam, Kandigai, Mambakam, and up to the perimeter of Kelambakam area, and this side up to Perungalatur and Crompet, sir. And with this pandemic, though we are having extreme challenges in reaching out to outreach camps and other things, we are trying to provide all these services with the best quality. And our chairperson, Professor Dr. Mala Madam, who is the managing trustee of Tagore Educational Trust, and our secretary, Mr. Manikantan, they are extremely focused on improving our centers, and they are trying to bring the centers closer to the hospital to provide more and more services for the catchment population near the hospital and this area also, because of the pandemic, most of the services are disrupted and they are more COVID specific. So we are trying to improve the coverage of other services also. And our respected Dean, Dr. Kumudha Lingaraj, she said she will join us very soon. And our respected Medical Superintendent, Sir, Dr. Karunanidhi, sir, both of them will be joining very soon, sir. So without further delay, with your permission, shall we proceed with your session, sir? It's muted, sir.
Okay, madam. Thank you for your kind words on the introduction. So I think the earlier session is over.
The first inaugural session is over, sir. Okay. We were just waiting for you to join so that, you know, we can start off with your guest of honor lecture as the first session, Omicron variant, what you need to know. Okay. So just give me 1 second, sir. Yes. I'll just, yes, sir. Meanwhile, I would request sir to just say a few welcoming words to Dr. Kulanaswamy, sir. I think Kannan sir is stepped out. Okay, fine, no problem. I would like to proceed for our next session, which is titled Omicron variant and what you need to know. This session will be addressed by our guest of honor, Dr. K. Kulanaswamy, sir, the former Director of Public Health. I'll give a very brief introduction. Many of us in the public health field are aware of human service done by Dr. Kulanaswamy, sir. And majority of us, the moment we put your picture on this invitation, we got so many calls saying that you are a very good speaker and you disseminate knowledge in so many webinars and forums, sir. We are extremely delighted to host you in our webinar. And the moment we put up this for Tamil Nadu Medical Council credit hours, we got a call from them and immediately 2 credit hours were sanctioned and an observer was appointed for our webinar. And we are in the middle of this pandemic, and today's session is going to be the real dissemination of information as well as real updates. So allow me to give a very, very brief update about your entire experience and service to the mankind. Dr. K. Kulanaswamy, sir, completed his education and currently he's taken up a lot of positions. I will start from the latest. In 2020, sir served as technical advisor for COVID-19 in the Commissionerate of Revenue Administration and Disaster Management. Before that, sir was Director of Public Health and Preventive Medicine in the Directorate of Public Health and Preventive Medicine. Sir, this service for 7 years, I believe, is where you make so much contribution, and your impressions and your footsteps we will try to follow, sir. And as Additional Director of Public Health and Preventive Medicine in the public primary system, you have upgraded a lot of infrastructure and systemic improvements in primary health centers. Sir also served as Joint Director of Public Health and Preventive Medicine. Again, very, very important positions for public health people like us to be inspired. Sir was on deputation for Masters in Applied Epidemiology course in ICMR institution. Sir also served as Deputy Director Research and Program Officer Training in Reproductive Child Health Project and Deputy Director of Health Services as well as Deputy Director of Health Services in Vellore, Theni districts, as well as started his career as Medical Officer in Nilgiris district. Sir, if I keep on reading, people will be missing your lecture. Please pardon me. I'm not really doing that because we want to listen to your lecture and want to benefit from all the insights you can provide for us in the middle of this pandemic with this variant circulating crazily around the world. Without delaying further, I request you to deliver your session titled Omicron Variant, What You Need to Know. Once again, from Tagore Medical College and the Departments of Community Medicine, Pharmacology and Central Research Lab, we extend our warmest welcomes to you, sir. Thank you.
Thank you very much for the kind words. Share screen. I think you have to give the permission for screen sharing. Permission for screen sharing. I think you can make us a co-host.
Yes, sir. Kannan sir will be doing it in a second.
Yeah, I've given the permission, sir. You can share the screen.
Yeah. Is it visible?
Yes, sir.
Okay. Okay. Now slides are visible. Slides are visible.
Slideshow, sir. It is visible.
Oh, fine. Thank you. Thank you. Okay. Good morning to all of you. So thank you for inviting me for this seminar, the online Zoom program. So now,
sir, you can go for the slideshow, sir. The slideshow format, so that.
Okay. Slideshow.
Yes.
So this one is okay. You want full screen or this?
Yes, sir. Full screen with the slideshow because right now all the other slides are in the left side.
Okay, I will close this.
Yes, sir. Yes, sir.
Now it's fine.
Thank you.
Okay. Thank you. So I'll make it very simple. The practical aspects, what we need to do. So at the end of the session, I think we'll be able to realize that what we are missing to do, that is very, very important. So this Omicron, this variant, as you all know, it had been detected in South Africa in November 2021. And at the same month, the WHO designated it as a variant of concern for the main reason the virus, the ability of the virus to spread is much faster than the earlier variants, including the Delta and other variants. The reason for that, the people say that the virus, instead of multiplying more in the alveoli, lung alveoli, they multiply more so in the bronchus. So the transmission, the viral load appears to be very high in the for the spread of the virus. That is the main reason that people have found. And why this Omicron may become a major challenge. That is again the point which I already explained, characterized by very high viral load. Therefore, the transmissible, the ability to infect people is very high. Then breakthrough infections among the vaccinated people also do occur, and reinfections also occur. But both the above points need to be studied in detail. The data which is emerging from UK shows that it is really causing a serious problem. Perhaps it may lead to a third wave in countries like India. Then the severity of the Omicron. So people say that the severity is not very high, but we should understand one fact: the people who are already healthy, the people who are vaccinated, for them there may not be, among these group, it may be very mild. So that we cannot take it for granted. But once it affects the people unvaccinated or the people who had not been infected naturally, and who have not received the vaccine, 50 plus or 60 plus, and with the comorbid conditions are likely to perish. So that means the deaths may be focused among this particular group of people who are yet to get vaccinated or partially vaccinated, and also they are having the innate vulnerability due to comorbid conditions or any other condition. Particularly the people, the direct, the family relatives of the people who had a very severe disease earlier are likely to again when they are being infected. So any unvaccinated person is there in such families, and they are likely to be. So we know that this epidemic wiped out families, brothers, siblings. So it clearly indicates there is a kind of called innate immunity. The same way, the opposite of that, there is an innate vulnerability. So we need to ask the history. Did anyone in your family had a severe disease? If anyone in your family perished due to this COVID-19 during the first wave or the second wave, it will be a very useful clue to predict the course of the infection in such people, particularly the unvaccinated and comorbid conditions. The third wave, again, we should all understand this rogue virus. Rogue virus means the rogue virus means we are not sure whether this virus is the virus jumped from animals and evolved in nature, or we don't know whether this virus is from the laboratory origin. So still it is there is no clinching evidence, but there is an every reason to believe that this virus is a rogue virus of an evil empire. So that is the very important thing that we should remember. So the first wave and second wave were in different phases in different geographical areas globally. So classically, the US, European countries, and then followed by Maharashtra, Delhi, then it follows in Tamil Nadu. It means, so we cannot, the earlier experience is very clear. So we cannot say anything other than other than telling that the third wave, other than predicting that the third wave is approaching India. So definitely, but luckily, so it gives a clue. The rest of the world gives a clue what is remaining, what is the remaining inside. So again, so then we have to very carefully look for the events unfolding in other countries as well as in other states in India. So that will give a very, very vital and valid clue how the virus will behave in Tamil Nadu based on the first wave and second wave experience. Then it means, so it means it very clearly. So what we predict naturally, if it is a natural influenza like a respiratory virus, the first wave, second wave, then the third wave will be milder and smaller. Then it will become that pandemic will come to an end. Only then the local clusters or the focal outbreaks may occur. But here we are not able to predict anything. That is very, very important. Even if it behaves like the natural virus, then what will happen? The healthy people one side, children on the other side, those people who had already been infected on the one side, those people who have received the 2 doses of the vaccine is on one side. So who is remaining? The remaining vulnerable people, 50 plus without vaccination or partial vaccination with uncontrolled comorbid conditions. So that particular population may be facing a very serious trouble in the coming third wave. That is the conclusion. That is the assumption we can take. So that means we need to motivate people to get themselves vaccinated and continue to follow the COVID appropriate behaviors. Otherwise, we may also end up in a third wave. And again, what needs to be done to avoid the third wave? To ensure that the existing RT-PCR test captures the infection. Yes, that had been one conclusive thing that we can be happy that the existing RT-PCR test, it detects the Omicron variant also. So that is also being continuously being monitored. Then to do genotyping of passengers and their contacts, the coming from the high prevalent countries, So anyhow, there are about 30 laboratories across the country, including one at the State Public Health Laboratory in Thanambet and DPH office. The State Public Health Laboratory is having the genomic sequencing facility, but unfortunately, the capacity we able to do the sampling only for about 2,000 samples per month. So may not be I think that capacity to do the genomic genotyping has to be increased across the country. That is one thing that not only for this particular COVID-19 virus, for that matter. So this will help in diagnosing, categorizing other types of viruses, also including the dengue 1, 2, 3, 4, and other kinds of viruses. That is very, very important. This is one this is one lesson that we learn from the diagnostic facilities, genotyping facilities across the country needs to be improved. That is very, very important. Still, for the information, for the kind information, so most of the patients, even in the premier institution of the state or the country, admitted as a pyrexia of unknown origin, PUO, and they are discharged at the time of discharge also after a week or 10 days. They are called as discharged. In the discharge summary, we can see PUO. Some people even think PUO is a type of fever. So the highest possible result. So when we did the fever project in Krishnagiri and Nilgiris district with Manipal and CDC Atlanta and NCDC support, then the highest percentage which was achieved for this entire country is somewhere between 55 to 60%. It means about 40% of the fever cases, they are admitted as a PUO, they are discharged as a PUO. This is the state of affairs, very clearly indicating in private sector as well in the government sector. Still, we need to improve our diagnostic capacity to a great extent. That is a lesson that we learn. Then can travel restrictions and screening prevent Omicron transmission? They must be very, very clear and objective. So these all having only the newspaper value. It doesn't have the practical public health value to interrupt transmission. This is not an yellow fever. Where we can do the quarantine and the vaccination, yellow fever vaccination. So anybody who's traveling to these 40 and odd countries notified by the WHO, they should take a vaccine 10 days before leaving the country to such destinations. Or anybody is coming from such a destination coming to India, they should have the valid yellow fever certificate. So I think this yellow fever, these measures are able to keep the diseases in check. And similarly, EVD also, Ebola viral disease also, to a greater extent, the measures, the public health measures have taken, including the quarantine, isolation, and other measures, able to keep the infection in check. But that is not the case with the influenza like illness or any respiratory disease. So what we are doing, so most often, so it has been the activities, what action the public health department, what action the medical fraternity do is determined worldwide by the politicians and the administrators, so not by the public health or the medical people. This is one sorry state of affair that is there in the pandemic management, in this COVID-19 pandemic management. So to blunt truth, so these restrictions cannot prevent the transmission. That is very, very clear, because asymptomatic persons are there. Transmissibility before the onset of symptoms, transmissibility after the symptoms subside, then inability of the RT-PCR test or any other lab test to capture 100%. Even if you take the nasal swab and the throat swab, we can capture about 80 to 85% if we take the sample at the appropriate time. So these measures help in building a confidence among the public, and this may help in monitoring, and this may help in delaying the transmission of the infection. So this is that's all these measures will help. So then if that is the case, then where should we focus? That's a very important question that we should understand, and we should answer very honestly. The 7 principles of transmission prevention, I'm not going to detail except on one aspect, ventilation, which nobody talks about it. So the vaccination, including a booster dose, preferably a killed whole virus preparation. Even somebody had taken other vaccines, 2 doses, they had natural infection. There is no need for any booster dose. So there is no natural infection. They had taken any vaccine 2 doses. So now it is better they go for a booster dose with the whole virus preparation, killed virus. So that killed vaccine, like this, the age-old technology.
Excuse me, sir. Your slides are not changing, sir. It is in the first slide only, sir.
Oh, I see. You could have told me. now it is.
Yes, sir. 7 principles of transmission. Yes,
Okay,
sir.
okay. Maybe because in this full slide view it is not changing. I don't know the reason.
Now it is visible.
But anyhow, I will at the end of the I will WhatsApp the slides to you. You can share with all.
Thank you, sir. Thank you.
I think now it is visible. I will go in with edit mode. So the booster,
Yes, sir.
we are talking about the booster. Then universal wearing of face mask. We all believe that face mask and this PPE alone is sufficient. No, that is unfortunately no. See, the hand washing, sanitization of the surfaces, infection control measures, ventilation, vaccination, since all these measures are being followed only, then this wearing the face mask is effective. Face mask are it's not like a deep sea diving suit wherein the water doesn't enter even at whatever the depth of the individual, the diver dives. So that is very important that we should know. The effectiveness of face masks depends on various other factors. The face mask in an open place, the face mask in a well ventilated place, the face mask in a closed and contained and crowded space. Closed, contained and crowded place, the face mask cannot assure a protection. Maybe it offers some kind of to some extent some protection. What I'm trying to say, I'm not trying to say that face mask has no value. That's not the point. The face mask is effective in a well ventilated place. The well infection control protocols, the disinfection protocols are followed, hand wash practice is followed, the screening procedures are followed. If all other measures are followed, then the face mask offers a very good, close to 100% protection it gives. That is why we call the face mask as N95, because it gives only 95% protection. Even the European standard, the mask give only 99% protection. So there is so unless the other measures are being taken, this face mask will not be of any use. That we should remember. Then frequent hand wash, then disinfection of surfaces frequently touched by hands. Unfortunately, we are not believing in that. Then social distancing, they should understand what is social distancing, avoiding unnecessary attending events where there is a crowd, likely to be large number of large gatherings are there. Then physical distance. Physical distance is different from social distancing. Wherever we go, try to maintain 2 meters distance from one person to another person, whether we are standing in a queue, whether we are going for a meeting, whether we are going for any place. So this is 2 meters. Then lastly, good ventilation by opening doors and windows and additional pedestal fans and exhaust fans, simple measures that will increase the ventilation. So these are the 7 principles. See, you look at cinema theaters are functioning. Shopping malls are functioning, our offices are functioning, government and private offices are functioning, showrooms are functioning, textile showrooms, jewelry showrooms. They are all the classical spaces, classical closed and contained spaces for amplification of the infections. And another potential place where the infection can be amplified is hospital. So hospital, nowhere in the last 2-3 weeks, I have visited a few hospitals in both private sector and government sector. No screening, no mask, no hand washing, no the staffing at the entrance, no COVID-19 protocols. People are standing in the queue in the pharmacy, people are standing in the queue in the laboratory, in the diagnostic center. The afternoon between the 3 o'clock to 5 o'clock, so many people are in the cash counter. So there is an ideal situation prevailing in most of the hospitals, which can act as an amplifier of the disease. Then again, so for doctors and nurses and other healthcare professional, what we should know, one important fact is you just analyze. I think one of the students can also take it as a research also. It is a very important research question also. See, which is the most dangerous commonly prevalent microorganism for healthcare personnel is multi-drug resistant Mycobacterium tuberculosis. In my experience, I have seen nurses, doctors, and other people who are very closely working with the patients. They are the most vulnerable for the multi-drug resistant, and some of them died also. I know some of the nurses and doctors died also. So we should, whether there is an COVID-19 is there or not, in the interest of the healthcare personnel and the medical people who are working in the hospital, make sure that every patient entering into a healthcare facility is wearing a mask. Make sure that every visitor, make sure that every healthcare personnel, they are using the mask when they are in the work environment. That is very, very important. Even if COVID-19 is not there, it comes to an end. It is an opportunity for us to enforce discipline among the general public, patients and visitors. At least the people who are entering into a clinic or a primary health center or a outreach camp or whatever the situation it may be, it is very, very important that we should use this opportunity to make sure. Then the case management, as far as the case management, so the reports coming from the South Africa and UK and also Netherlands is not much different from the earlier COVID-19 and its variant. So it almost remains the same. But fortunately, we are having better drugs, including some of the oral drugs, the antiviral drugs, which are very effective, which are said to be effective against the COVID-19. So availability of oxygen infrastructure, the better control of comorbid conditions. We know the second way we have seen mucormycosis. What we have read in microbiology and textbooks, we have really seen the tragedy, mucormycosis tragedy during the second wave. So the control of comorbid conditions, then booster dose for all healthcare personnel. So I'm strongly advocating a booster dose for all healthcare personnel, but still the government of India has not taken the policy of the 6 months after the second dose, 4 months also some people say, 4 to 6 months after the second dose, preferably with a killed whole virus preparation is likely to offer a better protection so that we can be better prepared to face the third wave if at all it comes. So this slide is very, very important. WHO slide. This had been released almost 1.5 years back, but we are not understanding the significance of this. The crowded places, close contact settings, so particularly during the dining tables where we don't wear the mask also. Then confined and enclosed spaces. So then if these confined and enclosed spaces are there, then if there is an overlapping, if you see the crowded, close contact settings, confined and enclosed spaces, cinema theater, shopping malls, textile and jewelry showrooms, any departmental store which is closed on all sides and there is no ventilation, so then the risk is very, very high. So many of the hospitals also, many of the scan centers, hospitals, laboratories also function in the same way. So now I'm focusing more on ventilation in healthcare facilities. The WHO recommendation This is not, these recommendations did not come after the COVID-19. These recommendations had been given much earlier to prevent all kinds of infections within the hospital settings. To help prevent airborne infections, adequate ventilation in healthcare facilities in all patient care areas is necessary. Then minimum hourly ventilation, air change per rate, 160 liters per second per patient. Normally, if the windows and doors are open, we use proper exhaust fans, I think we can achieve with ease. 60 liters per second per patient for general wards and outpatient departments, 2.5 liters per second per cubic meter. So I think these calculations may appear to be very complex, but this in simple terms, you keep doors and windows open. Use some exhaust fans, at least in bathrooms and steps and other places, so that it will suck and send the air out, so that the air change is improves. That's all. It's a very simple thing. But the measurements appears to be this engineering. But you can take the advice of an air conditioning and ventilation. There are specialist engineers who have done post graduation in that and who have a lot of practical experience. So the ventilation, the air condition, we should understand there are basically two types of air conditioning. One air conditioning is it keeps on recirculating the air which is already cooled from within. So that's what most of the air conditioning systems, particularly the split AC and window AC, the car air conditioning systems are working. In that case, the same air, but here the advantage is the cooled air. So the energy spent, the power spent, fuel or the power spent is very low. But if we use every time we use a fresh air, then the power consumption increases. That is why in the central air conditioning system, so the air change you should keep at the maximum, so that to ensure that the required air conditioning, the air change per hour occurs. But unfortunately, in cinema theaters and other centralized AC mechanisms, nobody uses nobody keeps at the maximum level. People keep at the low level. So practically there is no air change. It keeps on circulating the air which is already inside that contained, closed and contained space. That is a very, very important. So then again, the aerosol generating procedures, that is intubation, ICU and other places where we are doing these procedures. So the recommendation 2 should be followed. Then if the agent is airborne, as in the case of COVID-19, then recommendation 2 and 3 should also be followed. Again, the point which I made, protection by PPE will be complete only when the first level administrative controls and second level engineering and environment controls are properly in place. PPE, please again remember, PPEs are not deep sea diving suits. That is why the infection occurs among even the nurses and doctors who are following the full protection. Also the infection occurs. Recently I visited scan center, diagnostic center. So where antenatal mothers are sitting, there is no hand wash. The entire room is air conditioned. Only the face masking is enforced. The entire cabins and other places are air conditioned. So the same air keeps on circulating from morning 9 o'clock to night 9 o'clock, perhaps sometimes 10 o'clock or 10 p.m. So then there is an absolute chance for everybody who is visiting that place is likely to get COVID-19 infection. So the same situation continues in many places. So unfortunately, the radiologist is using full PPE, and in fact he is using double mask, and he strongly believes that the PPEs alone will protect. No, it's unfortunately it's no. Unless the other measures, as I have mentioned, the ventilation and hand hygiene, the surface cleaning is being practiced, then this the effectiveness of PPE and mask becomes questionable. Then the first level administrative control, proper procedures for triage of patients, anybody with the fever, cough, cold, follow the protocol at the entrance itself, the OP, detecting infections early among the patients, among the visitors, among the doctors and nurses, separating infectious disease patients from other patients. Recently, when I visited an hospital, the pediatric patients, it is a pediatric ward. Some adult TB patients are allotted some 4-5 beds in one end of the general ward. It cannot follow such kind of practices. Then transporting the patient safely, that is also the how to transport the patients, educating the patients on staff COVID appropriate behavior, then designating responsibilities, who should ensure that the soap is available, who should ensure that this hand wash is available, who should ensure that hand wash is the hand sanitizer is not taken by somebody for other purpose, so that some accident poisoning occurs. So all kind of responsibilities is very important, and this is the first level of administrative controls. The second level of control is the environmental and engineering controls. Engineering control is mainly ventilation based and spatial separation. This cleaning and disinfection, again, that is very important. We know that 1% hypochlorite solution, 5% Lysol, they are very effective in the other area, the external area where there is a lot of organic matter is there, that can be disinfected with bleaching powder and lime to cut down the cost at the ratio of 1:5. Then proper personal protective. This is the third level of the infection control. Unless the first level and the second level are in proper place, then the third level alone may not be effective. Unfortunately, doctors and nurses believe that third level protection alone will sufficient for arresting the transmission. Then ventilation methods, natural ventilation, mechanical and hybrid, ventilation rate, airflow direction. The ventilation rate we have already mentioned, 12 to 24, depending on the air change requirement in that particular workplace. Then airflow direction, it always go from the infectious clean to should be from clean to less clean zone, then it goes to out. Then air distribution and air flow pattern. So for example, you are keeping a pedestal fan, then the air from your back or from the side and the patient, it should move out. So if you keep the pedestal fan in an improper place, then whatever the patient the infection brings, then that will directly flow into our face. That is very important. Direction of airflow is very important. The hospitals constructed 50 years back or 100 years back, they are well ventilated. You can see the windows, you can see the spaces. But you compare the hospitals which are the current day hospitals, then high efficiency particulate HEPA filters. So these can be installed at suitable places, and these filters will be, HEPA means high efficiency particular air filter. So if you can install these filters, it will reduce the load. But here the most important thing is these filters have to be properly positioned, properly maintained. That is very important. Otherwise, it will give a very false sense of security. That is also very important. Offices, schools, classrooms, workplaces, shops, in your college also. So they should also, the doors and windows are open and proper exhaust fans are fixed so that the proper ventilation is being maintained. Exhaust fans are very good tool for improving the ventilation. Again, the pedestal fans. I know one doctor from Andhra Pradesh. He is practicing. He is a surgeon in US. He is using a very large consultation room with the proper exhaust fans and ventilation. For the last 2 years, continuously he is doing the practice, infection-free practice. Neither he developed any infection nor his patients are visitors. The same way, many of the primary health centers. That is why in the infection rate is, please understand, the infection rate is very low in outreach fever camps conducted by public health department and local administration, is on community medicine departments in the field setting, in the open space with the proper mask and other precautionary measures. The infection rate, COVID-19 infection rate is very low when compared to the doctors, nurses, healthcare personnel who are working in institutions in a closed setting. So this itself is a telltale evidence that ventilation plays a major role. Suppose you are standing in the open space, you are not wearing a mask. The patient also, somebody who is an asymptomatic person is also not wearing the mask. The air flows from your side. Suppose you are standing on the east and your friend is standing on the west. The air flows from the east to west. There is absolutely no chance of transmission. You getting the infection from such individual. But we cannot decide the position every time. So simple face mask in open places is very, very efficient. So that is why in weekly shanties, large gatherings, but unfortunately the restrictions we level. So the restrictions, where do we level the restrictions? The chicken shop, mutton shop, fish market, the people who are selling the vegetables on cart. So we lay hands on them. So such measures are absolutely, but whereas the cinema theaters, shopping malls and other places are functioning without any restriction, open ground. So we should promote the open space utilization. Then open space utilization, good ventilation. So these measures will definitely help not only for this COVID-19 Omicron variant, but also for all kinds of respiratory infections and infections which are spread through the hands. So that is why I made a very, I am not sure whether anyone is talking about ventilation in the whole COVID-19 pandemic. So public health measures are not given importance. The public health, see the screening, the tracking, all those things are absolutely, they don't give the desired results. So where should we focus? We should focus on the people's behavior, our buildings, our mechanism, how we act. These are all the important things that we should do. Okay, thank you. So if any, I think the focus should be more on ventilation, vaccination, and hygiene, environmental hygiene, and other measures. So if we follow these measures, we can easily manage Omicron variant also. Then one important point. So this Omicron may be a blessing in disguise also, because the mild varieties, finally it will become a common cold type of infection, but that we are not very sure about. But the indications in Europe is indicating otherwise. So we must be very careful, prepare for the unexpected. Expect the unexpected and prepare well. That is the lesson that we learn from the first wave and second wave. Thank you very much.
Thank you, sir. Thank you for this wonderful session. As you have correctly highlighted, no one is talking about this content. I myself attend 2-3 webinars in a day on COVID-19 or related to Omicron. And except for a passing remark about engineering measures, this kind of detailed presentation I have not attended so far. Thank you so much. Sir, if you stop screen sharing, we'll have a face-to-face interaction.
Sure.
Yes, sir. So I'm very happy to see that you have mentioned such a detailed spotlight on the first level administrative measures, second level environmental and engineering controls, and third level is the PPE. Rather, we are doing it in the reverse order, putting so much pressure on personal protective equipment such as masks and the hazmat kind of suits. And you correctly pointed out that in spite of wearing these things, the healthcare providers are infected. In spite of receiving vaccinations, the breakthrough infections are happening. That could be the real point from your lesson, that coming from the bottom of the pyramid, starting with PPE and not buttressing with the second level environmental engineering measures and administrative efforts from top level, is not going to be the entire package of toolkit we have to actually execute at this point of time to effectively tackle this pandemic. Thank you so much, sir. As you said, we look forward to receiving your PPT in the mail or WhatsApp, so that we'll keep on educating our interns and healthcare providers in the hospital. Every week we will do one sensitization session on these measures, especially the hospital team has to be sensitized about these measures. I'll talk to my Dean Madam and MS sir immediately. What can be done at this level? Simple measures, as you said, pedestal fans, they are everywhere, but they are not being utilized in this angle. So I think that is a very valuable lesson. Already resources are available here. We just need to reorient our thinking and address this issue. Thank you so much. Now the session is open for interaction with our guest of honor speaker, Dr. Kodandaswamy sir. I would like to invite my colleagues in the department who are attending the session, my interns who are attending the session, my postgraduates. All of you have this wonderful opportunity to interact with this expert who has shared a wide breadth of knowledge coming from the administration. And also sir repeatedly said he's visiting a lot of variety of healthcare setting, whether it is primary care setting or a corporate setting or individual practitioner from Andhra Pradesh, Tamil Nadu and South India. So this is the right time for us to interact. I would start off, sir. You mentioned about your personal recommendations to the authorities or policy makers about booster doses for healthcare providers. You're advocating for that. Can you shed a little bit more light on this point, sir?
Yes, actually, the anyone who received 2 doses plus natural infection either before or after, booster dose may not be necessary. But the people who have received 2 doses but no natural infection. So now there is a school of thought, this adenoviruses used as carriers. If we go for a booster, so there is a possibility that the human body might have generated antibodies against the adenoviruses themselves, so the efficiency of that may be less. And also the age of that is why the Russian vaccine, they are using the another adenovirus for the second dose. So the first dose and second dose are not the same in the Russian vaccine. And the age-old technology, whether it is anti-rabies vaccine or any other viral the vaccine where we use the killed vaccine, so the whole virus is harvested. So that means on every component. So every component of the virus. So here, so the vaccines which are, there are some vaccines which are manufactured against the disease-causing portion of the COVID-19. So once the mutations and the variant occur, so the probability of that escaping the earlier vaccine may be very high. So that is why we are advocating, at least for the booster dose as a policy decision, we should go for the whole virus harvested killed vaccine. So that will give a better protection. Those who have received a natural infection, there is no need for that. They can take any vaccine.
Yes, sir. That is a very, very informative nugget you have given us, the variety of vaccines and the different types of immunity elicited by these newer technologies of vaccine. Coming to me, sir, I have received my first dose in January and second dose in March. Now it's almost like 7-8 months after receiving my second dose of Covishield. And there is a lot of recent peer print and other review articles saying that there is a waning of this immunity. So coming to the Indian scenario, we don't have mRNA and other vaccines, but with your expertise and know-how in the way the policies are being devised at the highest order, as a healthcare provider, are we looking towards receiving any third or booster dose in the next couple of months, sir?
Actually, I think there are 3 components to answer in your question, one single question. A study in Singapore, the SARS-CoV-1, which happened in, I think, almost about 22 decades back, still the immunity, although the antibody levels are not there, still the immunity is not measured only by antibody levels. It has the other component, cell-mediated component also. So that is a good news. so that the immunity, even if we are not having the antibodies, still there is likely to be the immunity. But here one important thing is, so the immunity of the vaccine-induced immunity, in the case of swine flu and other influenza vaccines, it is of a very shorter duration. And here, unexpectedly, it's not the again it is not in comparison with the natural phenomena of the viruses, the influenza respiratory viruses. So here also the immunity is long lasting with the vaccine. That is another positive point. But so with taking these things into consideration, I think the booster dose with the whole virus vaccine will be preferred. So why I am advocating for healthcare, I have not mentioned the comorbid condition people. Why I am particularly focusing on healthcare personnel, the simple reason, we are high frequency exposed people. Our frequency level of getting exposed is very high when compared to people in the general population. And again, the dose to which we are exposed, the people with this, obviously with the symptomatic people with the high virus in circulation, only they are coming to us for treatment. So high dose exposure, high frequency exposure. Keeping these two in mind, we are advocating the third dose for the healthcare personnel, so that we can face the third wave much more. Our confidence level will be much more when compared to other people. So that is the reason.
Yeah. Last thing, sir, during your first part of the presentation, you highlighted the transmissibility of this variant before and after the onset of symptoms. So for the benefit of my young doctors who are actually, as you said, they are posted in the fever clinics, they are posted in the OPDs, they are the people who are actually frequently seeing these clients. So can you just, as a closing message, take home message, can you summarize the learning points on this transmissibility awareness before and after onset of clinical symptoms?
Yes, so that means that is why we are recommending the infrared, non-touch infrared thermometer for screening. So it detects fever even a day before the traditional thermometer. So that means at least one day before we can diagnose the fever. But before the onset of the fever, maybe perhaps 2 to 3 days itself, the patient is infectious. Majority of the patients are infectious. So we don't know the screening will stop the infection. It won't. So yeah. So that what I'm trying to say, as in the case of HIV, universal precautions with all patients. So the same kind of universal care with all patients, expecting this particular individual may be a potentially COVID-19. So and that's very, very important. And again, somebody produces a negative result, we cannot take it for granted. That the sample might have been taken at an inappropriate time, or the sample might have been might not have captured the virus, but taken the virus in the swab. So the test may not be real negative. All the positives, RT-PCR positives are real positives, but all the negatives are not real negatives. So that also we must be very, very careful. And also, a small minority of the patients, even after 10 days, normally by 10 days, they become close to 100% of the patients, they become negative. But a few patients, still they continue to be on the 11th day, 12th day, or even we have seen patients, they are positive for 20 days also. So we must be very, very, even recovered patients also, we must be careful. That is very important. Another important message that I like to, which although I have not focused on this public health measure, so the one important thing, the course of illness that we should understand, the course of illness, initially the symptoms, then subsequently the biochemical markers, that very important. The simple C-reactive protein, the simple ESR, the blood count, they give a clue for what is waiting. Then subsequently the CT scan. Then subsequently only the oxygen saturation falls, the pulse oximeter, the roller pulse oximeter comes. Then finally the respiratory distress comes when the patient becomes very critically ill and the lung involvement is very, very considerable. So, so we should, from the symptoms, from the biochemical investigations, from the CT or X-ray findings, then the pulse oximeter finding, then finally the respiratory distress. This is the course of, so we can detect much earlier. So the role of biochemical tests are very, very important. But unfortunately, when the breathlessness comes, you immediately come to the hospital. It has no meaning. Even one person is positive in one family, the rest of the family members also should continue to be monitored, investigated. That is also very important to prevent further cases and to prevent, to save lives. That's another message that we should learn from this.
Thank you, sir, for again flagging the household transmissions, especially in the last message you have left with us. I'm very curious, sir, given your busy schedule and administrative visits and all these things, how do you keep your knowledge updates? How much time do you spend reading the science emerging on COVID, and how do you keep reading the latest guidelines, latest science from Hong Kong, Singapore, everything? Can you share your secrets?
Attending seminars, suppose today you have invited me, so then it is forcing me to prepare. So accepting lectures and educating people at whatever level, whether they are working in industrial people or general public or press people, keeping in touch with the press people also, very, very open-ended, friendly people. They ask a very important question. So keeping ourselves open is very, very important. And also, as you have rightly said, so after retirement, I am relatively free. But even before retirement, so when I used to go to Delhi and other places, so while going, I used to get books in Higginbotham's in Chennai airport. Then the people in the bookshop, they became very friendly. So then next time, one young boy, he asked me, "Sir, you are buying so many books every time, at least minimum 2-3 books. Do you really, you are buying for your library, or you are buying for yourself, or for reading? Do you read all books?" Then I told him very coolly, "Sir, do you remember what is the book I bought last time?" So he didn't remember, but then I told him, "So you take another book. So any book, so we know what are the, first select what is the book which is required for us. Then go through the contents. So what is the portion which is required for? Go through it. Finish, simple. Then you give the book to the library or give the book to somebody else. And if the book is so good, then keep it for yourself. That's very important. Then always, wherever you go, keep a book of interest, a book of which is useful for your day-to-day work or life. You keep it in your bag. When you are waiting in the airport, when you are traveling in the car, when you are flying, or when you are going by train, keep reading and finish it up. That is the secret of reading books. On an average, I used to read about at least 3-4 new books per month.
Wonderful.
Even now, 3-4 new books.
Wonderful, sir. I think this is very inspirational to listen to such a great leader in our own domain, because most of the times we listen to other people and say, they are different to us.
The recent book, one second, madam. The recent book, one written by one B.N. Murthy and another of his friend. So how to predict the various kinds of infectious diseases and modeling. So I will send the link to you.
Please,
so
sir.
You can also, I think that is the most useful book recently I have gone through the last week. So I will send the link to you, so you can go through it.
Yes.
All of your students' library also, you can keep a copy. Thank you. Thank you for
wonderful, sir. Thank you so much, sir. This is an inspirational interactive hour with us. Apart from the Omicron updates you have provided us, you also gave an inspiration how we can model our life and serve the communities and update our knowledge, because knowledge is the real weapon by which we can dispel the darkness in this world. Thank you so much, sir. With your schedule permits, I would like to invite you once again for teaching our postgraduates at a later date, not immediately to disturb you, because they'll benefit immensely from your wealth of knowledge. At the conclusion, I would like to thank on behalf of Tagore Medical College and Department of Community Medicine, Pharmacology and Central Research Lab for you taking time from your busiest schedule, but we are the real beneficiaries because your message will be amplified through our voices, and your PPT and your knowledge will be amplified through our actions, and we look forward to interact with you once again, sir. Thank you so much. Thank you, sir. Thank you so much. So with that farewell to Dr. Kolandaswamy, sir, we'll take a short break for 10 minutes. Now it is almost 11 o'clock. We'll convene at 11:10, and we will look forward to Dr. Kannan sir's session. A short break for 10 minutes. Yes. Welcome back once again. We have been listening from the morning to the experts such as Dr. Kolandasamy talking to us what we need to know about Omicron, especially in the middle of the pandemic emerging with new variants and putting in the pathway for us new challenges, how to address that. And Sir has given new information about administrative, environmental, and engineering controls that need to be in place along with personal protective measures we need to take at individual level. Now, moving on to the next agenda schedule in this program, Dr. Kannan, officer in charge of Central Research Lab and eminent virologist, immunologist of Tagore Medical College and Dental College, will be enlightening us about variants of COVID-19, and also he will lead us how the emergence of Omicron has been facilitated or enabled due to the failure of certain human behaviors. And all of us know Dr. Kannan, sir, is a guide and mentor for all of us when we think of research. The one godfather kind of figure that flashes in our mind is Kannan, sir. So he's the right person to address this gathering about COVID-19 variants and Omicron emergence. So, sir, without much further delay, we welcome you for this webinar and request you to deliver your session. Thank you so much.
Good morning, everyone. I'll share my screen now.
Yes, sir, the screen is visible.
Okay. So my topic is visible, not screen.
Can go to the slide.
Shall I go to the slide? Okay.
Yes, sir. The big slide format.
Slide is
the
visible.
Slides are visible. You can go to the slide show.
Presentation. Okay. Okay, good morning, everyone. So I'm going to take now on variants of COVID-19 in the context of Omicron emergence. So just I'll give a brief introduction on the morphology of coronavirus. So the coronavirus belongs to the coronavirus family in the nidovirales order. So this coronavirus, the name actually got because of the crown-like spikes on the outer surface of the virus. So it looks like a corona. So they named it as a coronavirus. They are minute in size. They are RNA virus. They have a single-stranded RNA as a nucleic acid material. The size range from the RNA size range from 26 to 32 kilograms per in length. So this is the structure of the SARS-CoV-2. So you can see it is an enveloped virus. What you see outside the envelope. So the envelope are started with the small envelope glycoprotein. We call it as E protein. Then you have the spike protein and membrane glycoprotein. Spike protein is called as the S protein, and the membrane glycoprotein we call it as the M protein. And inside you can see the single-stranded RNA. The single-stranded RNA will be associated with the nucleic acid capsid phosphor protein. Okay, so this present COVID-19, so it actually all know that it emerged in a small business hub called as Wuhan. Suddenly the China experienced an outbreak at the end of 2019 that killed more than 1,800 and infected over 70,000 individuals within the first 50 days of this epidemic. Then this virus, then finally they reported that it is a member of beta group of coronavirus. So this novel virus, initially they named it as 2019 novel coronavirus by the Chinese researchers, but later on it went into the International Committee of Taxonomy of Viruses. They finally named it as the SARS-CoV-2, and the name of the disease was given as COVID-19. So what is unique about this virus compared to the previous similar virus, coronavirus, is that so the transmission rate is very high. The transmission rate is very high, and also the fatality and the virulence is also considerably high. And the the transmission rate is attributed to the reason of the genetic recombination event that occurred in the S protein, the spike protein. See the region, what we call it as the RBD, that is the receptor binding domain. So if you take each protein, the functional region of the protein, we call it as domain. Say the S protein, the spike protein that is present on the envelope of the virus. So there we have a domain, what we call it as the receptor binding domain. So this domain, the configuration of the domain has changed because of the mutation. And this helped the virus to bind tightly to the receptor of the host cell, that is our cell. And this is attributed to the enhanced transmission ability of this virus. Okay, so there are a lot of theories. So once the virus came into the picture, the people were very curious to know the origin of the virus. So, but one thing, the coronavirus has been already proved that it is a zoonotic disease. So they just worked out about the various possibilities. So they finally attributed that it is the bat. Bat is the primary host of this. Even for the SARS-CoV-2, the bat is the primary. So okay, so let us go back to the history. The coronavirus is not new. In 2003, actually, the Chinese population was first time infected with the virus, which caused the so-called SARS, what we call the severe acute respiratory syndrome, in a Guangdong province that is present in China. So the virus was confirmed later on as a member of beta coronavirus, and they named as the SARS-CoV. So the people who are infected with this SARS-CoV in 2003, the infected patients exhibited pneumonia-like symptoms, and with a diffuse alveolar injury, which led to acute respiratory distress syndrome, that is ARDS. And this SARS, as I told, initially emerged from China, and they started to spread rapidly around the globe with more than 8,000 infected persons and 776 diseases. So at that point of time, we all feared about a pandemic, but luckily this particular coronavirus came very quickly under the control. You can see the statistics, only 8,000 people around the globe got infected and only 776 people died. Later, a decade later, 2012, a couple of Saudi Arabian nationals were diagnosed with again the coronavirus. And the virus, again, they found similar to the SARS-CoV. So they named it as MERS-CoV, which means the Middle East Respiratory Syndrome Coronavirus. So again, the WHO reported the statistics, and again, it is not too alarming. Again, as we thought it's pandemic, and but it didn't go as a pandemic. It came into the control. Only 2,428 individuals were infected, and 838 deaths occurred. And then the epidemic came into the control and ended. And we never thought we are going to face again this corona again a decade later. Okay, so the MERS-CoV is a member of again the beta coronavirus subgroup, and phylogenetically diverse from other COVID viruses. So the infection of this MERS-CoV initiates with a mild upper respiratory injury, which again progresses with a severe respiratory disease. Similar to SARS coronavirus, the patients infected with this MERS also suffer with pneumonia, followed by ARDS and renal failure. Okay, so now we'll come into this SARS-CoV-2. By the end of 2019, China informed WHO, the Chinese government informed WHO that several cases of pneumonia with unfamiliar etiology. So a lot of scientists, they suspected that it may be because of the coronavirus, and some scientists, they raised the suspicion that the Hunan seafood market in Wuhan is the one which helped the virus spread. However, it was not where the outbreak was first emerged. I'll explain you. So, a lot of papers have started to come from Chinese researchers. So this is one which introduced the clinical features. So the title says the clinical features of patients infected with 2019 novel coronavirus in Wuhan. So they reported scientifically, officially about the outbreak, and they said that it's a novel coronavirus. And later on, some studies also suggested that it's the bat origin. It is not that market, which really the reason for the emergence of this virus. So the scientists, the researchers went into the detection of the origin, and they just had a thorough analysis of various animals in the vicinity, and they found initially that raccoon dogs and farm civets as the key reservoir of the infection. Only the few samples isolated. See, they food market. These cats were sold in the food market as the meat. You won't believe. And these samples, some of the samples showed the virus, but not in all the samples. But ultimately, they found this is a secondary host. It's not the primary host. So this would have occurred from the primary host. So a lot of research then went on. They found that the animals are the reservoirs of the SARS-CoV, and they attributed the bat. So the rhinopsid bat, you can just see why it is called the rhinoceros bat, because of its nose, which looks like a nose of a rhinoceros. Okay. So to take the reservoir of MERS, so they clearly proved that it is from the camel. It is from the camel. So they proved that it is from the camel, and finally also it went again into. So camels are only again the secondary host. They proved that the primary host are the bats. Okay, so very interesting. If you take say even influenza virus, it is basically a animals in animal origin. What they call it as host switching. See, mostly these viruses, the influenza virus, coronavirus, they live predominantly in the animal, but sometimes what happens, it jumps from host to host. Okay, in that case, sometimes it jumps to the human being. Okay, so most of its mutation, variants, you see, it all happens in the animals, not in humans. Okay, so sometimes this viruses, that's the reason why we have sudden outbreaks of these sort of viruses. Okay, it is there permanently present in animals and keep on evolving. Okay, sometimes jumps, the host switching, what we also call it as spillover event. So this leads to the emergence of this type of new variants. Okay, so in 2000, beginning of the 2020, a publication came wherein they just compared the SARS-CoV and SARS-CoV-2. And one important thing is the key host. So here they have put bat as the key host. Okay, and so all the other data they put, and data was published, which really gave an alert to the people that really a serious infection has come out. Okay, so let's see some molecular mechanism of viral attachment, because it is the one which really brought this SARS-CoV-2 as a very infectious one. So it is the glycoprotein spikes. So what we call it as a spike protein, which is present on the outer surface of the coronavirus, are responsible for the attachment and entry of the virus to the host cells. So this spike protein is having, as I told earlier, it contains the RBD, that is the receptor binding domain. It's a 3D structure. It goes and fits into the receptor. The receptor is ACE2, that is angiotensin converting enzyme 2, that is present on the host cell. So that will act as a cavity, and this domain, the 3D structure, goes and fits into this cavity. And it is very important that it should maintain the binding strength. The strength depends on the different configurations of this RBD. So the SARS-CoV-2 configuration is such a way that it would be able to bind tightly into this ACE2 receptor, and because of this van der Waals force and hydrogen bonding, so these all determined its efficacy in binding to this receptor. So if you take this domain, RBD domain, there will be different amino acids contributing for its binding. So here they have found that 6 RBD amino acids have been shown to be critical in binding to this ACE2 receptor. And this also determines the host range. Very important. Okay. So the ACE2 receptor may be different in different animals. So the binding, the RBD amino acids also will be different So it contributes not only for the binding strength, also for the host range of this SARS-CoV virus in animals. So when they analyzed this coordinates, the amino acids that binds to this ACE2 receptor, both are different between the SARS-CoV and SARS-CoV-2. Both are different. So the 6 amino acids, as I said, so the alphabet denotes the amino acid. Okay, so these terminologies are very important to understand. So this alphabet Y determines the name of an amino acid. 442 is the position of the amino acid. Likewise, the alphabets, all the alphabets you see here, all determines the amino acid. The name of the amino acid denotes the name of the amino acid, and the number denotes the position of the amino acid in this particular domain. That's the receptor binding domain. Okay, so there are 6 amino acids, both in SARS-CoV and SARS-CoV-2, but both are entirely different. That's the reason why the binding, the transmissibility, infectivity is totally different between the SARS-CoV and SARS-CoV-2. Okay, so the research has found that the SARS-CoV-2 seems to have an RBD that binds with a very high affinity to the ACE2 receptors, not only in humans but also in other animals like ferrets, cats, and other species. And any other species, see these humans, ferrets, cats, they all share some common receptor homology, ACE2. They are little homologous compared to the other distinct animals. So that's the reason why the SARS-CoV-2 can bind to the humans, also with the other some animals with the same homologous receptor, the ACE2 receptor. Okay. So how the SARS-CoV-2 would have emerged? So that is the question, right? So there are some theory. There's a purposeful manipulation that came out of the lab. They manipulated the coronavirus, and it was sent out of the lab purposefully or accidentally. So this is the one of the theory was going on long before, but there is no support regarding this. It's nature. See, as I told, it's a zoonotic disease, and continuously the animals have this coronavirus, the SARS-CoV. So it continuously mutates. Sometimes what happens, it spill over. See, as I told, the RBD should be specific to the ACE2 receptor of human. Okay, most of the times it never happens. That's the reason why the animal virus does not enter into the human and cause infection. But in case of this influenza virus and coronavirus, because of the high mutability, these receptors sometimes get mutated and could able to bind with the human ACE2 receptor. In that case, there will be a spillover. There will be a host switch. So this is what happens in the influenza virus. This is what happens in the coronavirus, and this is what happened in the SARS-CoV-2. Okay. So SARS-CoV-2, when it spilled over, this domain RBD, could able to bind to the human with high affinity, and it was selected by the nature. What we call it as a natural selection. There are so many SARS-CoV viruses. There are so many other coronaviruses. Okay, so these are all not be selected by the nature because of its low affinity to the receptor. So only those viruses which have high affinity to this receptor alone will be selected by the nature, and it will be propagated. It will be transmitted very fast, very quick. Okay, so that is what happened in the case of SARS-CoV. So there is an evolution. Okay, there is an evolution of this mutation in some animal, maybe the bats, and this would have been spilled over because of its the RBD domain, the receptor binding domain, because of its affinity for the ACE2 receptor of the human. So again, the purposeful manipulation, there is no evidence because we need evidence. Okay, so that we don't have any such evidence. It is improbable that the SARS-CoV-2 emerged through the laboratory manipulation. Okay, so only thing it is because of the natural selection. Even many researchers went to the genetic data of the SARS-CoV-2 and they found that it's not derived from any artificial virus backbone. Okay, it's very easily to identify whether it is manipulated or not. They found that it is not manipulated because we want to manipulate, we should have a virus backbone, the RNA backbone. We don't have any such evidence that they have taken a virus backbone and they have manipulated this virus. So purely this virus has emerged because of the natural selection, because of the spillover or the host species. Definitely it is a zoonotic disease, not the laboratory disease. Probably this virus may be evolved from the tissue culture. That is the only one thing you can attribute for the laboratory theory of the emergence of this virus. So the laboratory probably, see, they are going the coronavirus in Wuhan itself. They have a center wherein they are propagating the coronavirus. So probably there may be some mutation in the tissue culture, not inside the animal, inside the tissue culture. Probably it would have gone up from the lab, but the theory is still not proved. That is the only possibility, but not a manipulation. That is for sure. Okay. So before going into the Omicron as such, so let us see the basic genetic composition of this virus. You can see I have compared the SARS-CoV-2, SARS-CoV, and MERS-CoV. So it has the open reading frame. You can see the untranslated region, both the sides. So it starts with the open reading frame 1A and 1B. Then you have spike protein. Then you have some other gene here, and you can see the N protein here. Okay, so you can see a lot of differences. See here, the 3A here, the 4A. Okay, there are some minor changes, mutations that occur here in these places. Okay, so let us see now the theory. As I told, the spike protein, okay, would have evolved from the animals because of this homologous recombination. So two viruses, this is what happens even in the influenza virus. So two related viruses comes and there will be a recombination event. There will be a mixture of this that genetic material, the RNA, and a new type of RNA will develop. Probably the spike glycoprotein would have got reshuffled between two similar SARS-CoV viruses. So probably it would have evolved a RBD which has a very good affinity towards this ACE2 receptor. Okay. So initially the scientists found that this mutation at the region of 501 from N to T. So this is what happened, and that enhanced its binding affinity for this ACE2. So this is what would have happened in the animal, probably the human also. And once this had occurred, and the SARS-CoV-2 started to spread. Okay. Now let us see some terms. Okay, variant. So this is what you should know before going into the Omicron. So the SARS-CoV-2 variant. So what is this? The virus continuously evolves as it changes in the genetic code because of the genetic mutation that occur during the replication of the virus. So what is a variant? The variant has one or more mutations that differentiate from the other variants. Okay, so variants means that the differences, okay, in the genetic element between two SARS-CoV-2 viruses. So we call them as a variant, and all the variants to put together we call it as a lineage. All the variants to put together, so we can define. So this virus had come from this lineage. So Omicron came from this lineage. The Delta came from this lineage. So the lineage are a group of closely related viruses with a common ancestor. Okay. So we are going to talk much about the variant and lineage in the future slides. Okay. So there are various terms are introduced by WHO. So one is the variants being monitored. So once the variants started to evolve after the SARS-CoV-2, so the WHO came with monitoring these variants. Okay, so they keep on monitoring, and so they just find out whether these viruses are circulating continuously, or whether they are eliminated, or whether it is circulating at the lower levels. So they continuously monitor, and if they find any variant has some question of any infection, causing infection and spreading, then they put it as a variant of interest. Okay, so the viruses, when they fulfill this following criteria, will be put under the variant of interest by the WHO. They will have a specific genetic markers that are predicted to after transmission, diagnostics, therapeutics, or immune escape. And there should be evidence that it is the cause of an increased proportion of cases and unique outbreak cluster. So all this will be kept under the variant of interest. They limited in prevalence and expansion. That's the reason why they are in the variant of interest. And the final thing is the variant of concern. So, so they will have the attributes of the variant of interest, but apart from that, they should have other attributes like widespread interference with the diagnostic test targets, evidence of the substantially decreased susceptibility to one or more class of therapeutics, evidence of significantly decreased neutralization by the antibodies generated by our natural immunity or by vaccination, and the evidence of increased transmissibility and increased disease severity. So these are the two important things they take to put the variant into the variant of concern: severity and transmissibility. These two are very, very important criteria to take a variant as the variant of concern. Okay, so currently we have now till date 5 variants of concern, and we don't have variant of interest right now. We don't have variant of interest right now. It is not blank, but we have 5 variants of concern. You know very well about the Delta variant that has occurred, that created a second wave throughout the world, including India. Now we have got into the Omicron. Okay, so here you can see Omicron is described as P.1.1.529, and we have other nomenclatures. So here you can see the nomenclature by GSED and next strain clad 21K. So these things are all very important before understanding about the Omicron. Okay, so if you take Omicron, officially it was declared that in November 24, 2021, it was reported officially by the World Health Organization. They gave the name as P.1.1.529, and this new variant was first detected in the specimens collected on November 11, 2021 in Botswana, and on November 14, 2021 in South Africa. Okay, so on November 26, 2021, WHO named this as Omicron, and they gave the pangolin or pangol classification, that is P.1.1.529, and they put under the fifth variant of concern. On November 30th, 2021, the United States designated Omicron as the variant of concern officially. That is on November 30. And on December 1, 2021, the first confirmation of the US case of Omicron also was identified. Okay, so very interestingly, some papers are being published, still getting published. So one interesting paper is that they have found that the genome of this particular Omicron has the S protein, which produces S protein, that closely resembles to the receptor, ACE receptor, having high affinity towards the mouse ACE2 receptor rather than human. Human also they have very good affinity, but they also found it is peculiarly towards the mouse. We're able to go and bind, and they have a lot of affinity towards this particular Omicron RBD. So they have found that they have just gave an hypothesis that probably the Omicron variant would have a mouse origin, but still we await the research regarding this. Another interesting finding, they found that the Omicron, it thrives on the upper respiratory tract, not in the lower respiratory tract. They say that compared to Delta strain, it is 20 times, it can able to multiply 20 times in the upper respiratory tract, but it cannot able to multiply that effectively as the Delta variant, the lower respiratory tract. So that's the reason why so far we have found the Omicron cases either asymptomatic or the mild symptoms, but still again this has to be proved scientifically with a lot of other research. So still we are waiting for the research if this is going to be the truth, or this is going to be the scientific truth that they cannot multiply the lower respiratory tract. Then Omicron is going to be a blessing in disguise, as this Omicron can spread very fast with asymptomatic case or mild infection definitely it is going to contribute for the herd immunity, what we like to have. So you know the herd immunity, when it comes, definitely this COVID is going to put an end to this SARS-CoV-2. So Omicron, now people are just welcoming it. Some people and some people are just thinking whether it may go into the third wave. So only the research, future research is going to tell whether it's going to be a third wave or it's going to be a mild or asymptomatic and going to develop the herd immunity and going to uh, put the end to the SARS-CoV-2. So only the time has to tell. Okay, so a little bit before concluding my talk about this pangolin lineage nomenclature, because many newspapers I have seen this, they portrayed this pangolin lineage 5.1.1 point so on so and all. Okay, so this actually the short form of phylogenetic assignment of named global outbreak lineage. So it's actually a nomenclature system which contains a prefix, alphabetical prefix, and a numerical suffix, but not the numerical suffix. If you take, it is not more than 3 hierarchical levels. So what happens if, so when a variant comes, they name it as say B.1. B.1 is the variant. Okay, so say so once the B comes, so you start with the B.1. Then from the B.1, if any other variant emerges, it will be named as B.1.1. Again, any variant emerges from B.1.1, then it is called as B.1.1. Okay. But after that, any variant emerges from this, it will straight away named as the next, that is C.1. Okay. Okay, so there are additional classification. We saw the next strain or next clade nomenclature. It's very simple nomenclature. Year, they'll use the year, say 20, 21, 19, like that, with some other alphabets. Okay, to name these variants. Okay, WHO nomenclature is very simple. They name it with some Greek alphabet, you know, alpha, beta, gamma, and the present strain is named the Omicron. Omicron is the nomenclature of WHO. Okay. So the nomenclatures you have to be very, you should know why suddenly we calling it as Omicrons, why suddenly we calling it as a P.1.1259 and all. Okay, so this table will give you the nomenclature. So the next strain clad is 21K. Clad is 21K. The pangolin lineage, the present nomenclature is BA1. BA1, not the B.1.259. BA1, and the WHO has named it as Omicron. Yes. Okay. So the lineage B.1.1 529. So here you can see now it has been converted as the BA1. This is the WHO website. So the different nomenclatures have been given. So they have given the 5 variant of concern. Okay, the Omicron is named as 21K and BA1. Okay, so why this BA1? Okay, so now this Omicron lineage has again been split up. So they initially found it is a single strain. Now they have found some sub lineage of this Omicron. So what they did now, they are classified as BA1 and BA2, the alias, what they call it as alias, B alias. So BA1 and BA2. So BA1 is the one which we are now looking into, and that has come into the picture and has been diagnosed in various countries. This is BA1. So after some time, some scientists they deposited the Omicron genome sequence, and they found that there are some outliers. There are around 24 outliers mutations compared to the original Omicron. So they named it as a BA2. 2 days before, the third Omicron outlier has been reported in England, that is UK. So I don't know, maybe named again as a BA3, or I don't know, the nomenclature may change again. So in India, as far as the people who are suffering from Omicron, they only reported a scratchy throat, extreme tiredness, light fever, otherwise asymptomatic. Okay, not being hospitalized so far. So if it goes like this, it's well and good. Probably it may spread and create the herd immunity, what many scientists is welcoming. Okay, so how to detect this Omicron? So if you take the diagnostic kit, we actually detect various specific genes of this coronavirus. Say for SARS-CoV-2, we normally take N gene and RDRP. In India, if you take all the kits are detecting either this RDRP, N gene, or both, along with the E gene. Okay, but the mutation of concern for this Omicron is present in the S gene. Most of the RT-PCR kits in India, they don't have this S gene. Okay, but when this Omicron strain is subjected to the RT-PCR, which contains the S gene detection, so they will miss the S gene. It means that the S gene will not be detected. It can detect only the N gene and RDRP. So the missing S gene, what we call it is the S gene drop. S gene drop, and this S gene drop is used as the proxy test rather than going for the sequencing. Sequencing is very difficult and cumbersome, cannot be done in the large scale. So this missing S gene amplification in RT-PCR can be taken as the test. Okay, so in US, they have identified 27 tests, the ability to detect the S gene, this target failure S gene, the S gene dropout. Stack path is one of the kits by Thermo Fisher are being used in India recently in many states like Maharashtra, Karnataka, even in Tamil Nadu, they have started to use stack path. With the help of the tag path only, they identified this Omicron in the Tamil Nadu, right? So in the tag path, they have the S gene as one of the identification gene, wherein if the S gene is not amplified, then for sure they tell that it is because of the Omicron. Okay, why this BA2 became a concern? Because in BA2 Omicron state, there is no S gene dropout. This is where the trouble have started. The BA2 strains will have a S gene amplification in the RT-PCR code. So you may likely to miss this Omicron variant BA2. Okay, you may miss this. So again, now we have put in a trouble to evolve a new kit to find out the S gene dropout for this BA2 also. The present kits all detect only the BA1 Omicron strain by the S gene dropout, not the BA2. So we are in a deep concern. So that's what I told. Why it is important, because they test positive for the S gene on the PCR test. So you will miss the Omicron variant. Okay, so this is the Thermo Fisher kit. They detect for the S protein and the nucleocapsid protein. Okay, so December 19th, we got a news that the ICMR has approved, that is yesterday, they have approved the indigenously developed kit to detect the Delta and Omicron variants. So this S gene dropout has been included in one kit, probably within a few weeks. I think a lot of indigenous kits may be developed in India also, so that we can able to identify these Omicron cases very effectively. To conclude, so everyone know, so everyone will ask how to prevent myself from Omicron. Okay, the same prevention what we did in the second wave or first wave, or right now what we are continuing. Okay, so but very important, the first point, detection of the variants, the surveillance and the detection of variants. So the kits are now very much important. The new kits that can detect the Omicron variants are very important. So many companies have already got into it, and yesterday, as I said, one kit has been approved in fast track by ICMR for the detection of this Omicron variant. But other things are all, so we have to be keeping the social distance, mask, hand hygiene, so all the other things, and we have to decrease the window period for international travel. So normally they tell 72 hours, 48 hours, but now they want to reduce it as a 24 hours RT-PCR report. Right. So if I want to board like today, I have to do RT-PCR today, not 2 days. So all these things, and quarantining the international travelers. So all these things already the government has taken in various countries. They have taken various measures to prevent this Omicron. But as an individual, we have to follow the same social distancing, hand hygiene, putting the mask. All these things should be followed in future also. We should not be complacent. As right now, people say it is asymptomatic, Still, we don't have proper scientific evidence about how virulent this virus is. Only a few weeks old, this Omicron. So we have to be very careful and take all the precautions to keep ourselves prevented from this Omicron. Thank you.
Thank you, sir. That's a very wonderful session, helping us understand the entire evolutionary background about how the SARS-CoV evolved and how its connection with the evolution of Omicron. So quickly, if there are any questions from the audience, I would like all of you, faculties, interns, and doctors to interact with our guest speaker, expert speaker on immunology and virology, Dr. Kannan. This is the time for you to interact quickly because the presentation is a very scientific and technical, and you will not have another expert today to address these issues. The rest of the speakers are only with the background of public health and pharmacology. So this is the time for you to interact. So I would like to lead the interaction with one question, sir. Because you mentioned about this, because we also discussed earlier in our lab when the Omicron was emerging in the first week of December, the host jumping and immune evasion. Can you just add a little bit more, one or two highlight points when we connect this host jumping of this variant coming back with this kind of additional 30, 40, 50 mutations? And what is its connection to the immune evasion? Because right now we are talking about boosting the vaccination status, and earlier in the session, Dr. Kolanasamy sir is advocating for the healthcare providers to get a booster dose. So can you connect all these three points and the host jumping of the variant coming back to the humans, and again the immune evasion capacity of the variant, and then us talking about booster doses?
Okay. As far as the first thing is concerned with the host switching or spillover, it is purely because of the binding domain. See, when you take virus we always refer as homocytotrophic. In the sense, they will bind only with a particular species of animal, or say if we take a human virus, they cannot infect the animals. Likewise, the animal virus cannot infect the humans. We call it as homocytotrophic nature of the virus. That's the reason why when we want to grow the virus in the lab, we cannot use any animals. We normally see human virus, we grow maximum in the monkeys, which are closely related to the human beings. Or otherwise we use the cell culture, human cell cultures to grow this virus because of this homocytotrophic nature. Purely it is attributed to the binding domain. The binding domain is so specific for a particular issue, particular species. But as far as this coronavirus is concerned, sometimes mostly in the animals, not in humans. In the animals, what happens, sometimes this domain keep on getting mutated, or sometimes it may become specific for the humans. So that case, if the human comes into the contact, it gets spillover. Okay, this is number one. Number two, evading the immunity. Maybe I think it never evades the immunity. Any virus, it cannot evade immunity unless they are immunocompromised. Definitely, there are chances of some immunity. The only thing, the immune status, if you see latest COVID infections, not all the people got severe infection. It all depends upon the immune status of the individual. There is no question of any evasion from the immunity. But only when you talk in the perspective of vaccines, you can talk about the immune evasion. Because the vaccines, either it is a subunit vaccine, or it may be a killed vaccine, or it may be a vaccine that may be a cocktail vaccine, like maybe the adenovirus, where you put some gene of COVID virus. So they have developed antibodies only for some specific proteins. So that case, when there is a mutation in this protein, the virus can escape. Okay, so when you say they evade immunity, it pertains only to the vaccines. As far as the natural immunity is concerned, it's going to happen. Our vaccines, I'll tell you the drawback, it never develops local immunity. So the virus enters to the respiratory tract, but we all give intramuscular injection. Only the antibodies are developed in our blood, not locally in the respiratory tract. If you say take influenza virus, you give a live virus intranasal. The intranasal route, say it develops the local immunity in the form of IgA. specific for the influenza virus. So when the moment the virus enters, the virus will be neutralized, but not in the case of COVID virus. The virus can enter, it can multiply in the respiratory tract, but when it goes to the lower respiratory tract, probably this antibody that has been developed because of the vaccine can help us, and it can prevent the severity of the infection rather than preventing the infection as such. It can just only prevent the severity of the infection. Okay, so the present vaccine, that's the reason why many vaccinated people got the infection, but many are not hospitalized because the severity is less because of the systemic antibodies. So this is what actually the immune evasion. I don't think can evade the normal immune mechanism of our body.
Thank you, sir. That was a very detailed discussion about understanding the connection between these three elements. Thank you so much for your valuable session. It helped us to understand the Omicron emergence in the context of the pandemic for the past 2 years. Thank you so much. We would like to submit our gratitude for this wonderful session in this Omicron webinar undertaken by our 3 departments. Thank you so much. Now, we will move on to the next session in the schedule, that is Omicron and India status update. This session is supposed to be taken by me. As all of you are aware, this session is also initiated by the Department of Community Medicine. So I will jump on to my session because of we are running behind the schedule. So, sir, I'll share my screen. Is it visible? Sir, is my session visible? Can someone confirm whether my PPT is visible?
Yes, ma'am. Yes, ma'am.
Yes, madam, your PPT is visible.
Oh, sir. Thank you so much. Thank you so much once again. So my session, as I said, is Omicron in India and what is the status update. Some of the points might be overlapping with the earlier speakers, but I think for the benefit of a young audience, I would like to continue with this. My affiliations in this college include Central Research Lab as well as our Center for Integrated Oral Cancer Prevention and Research Network, which was the flagship initiative launched in September 2021 to spearhead our focused attention on prevention of oral cancer research through self-development of our tools. And all of you also know I'm also associated with Department of Community Medicine. So coming to my session objectives, at the end of the session today, from the morning, all of us have been focusing on Omicron. So towards the end of my session, it will be a little bit faster, roller coaster ride kind of thing. The participants will be able to understand what is the status of Omicron historically till date in India. So this is the latest article on December 18th released in Lancet. It's an editorial kind of op-ed kind of thing written. COVID-19, where do we go from here? So as I said, it's been 2 years and Kannan sir rightly said there has been a fatigue in the masses. We have been living with this virus for 2 years. There is so many restrictions in our freedoms, freedom of movement, freedom of liberties to congregate, celebrate, and weddings and birthdays and large gatherings. So where do we go from here? The highlighted areas talk about science has provided tools and evidence to control the pandemic, but the response has been shaped by political factors, lack of cooperation, often to the detriment of health. This is what exactly is determining the fate of the direction of the pandemic and emergence of variants, because the vaccine technologies have been not distributed equitably. That is one thing. Novel treatments have provided further options to prevent death and disability. That is what we are talking. Both preventives like vaccines, therapeutics like novel drugs are emerging. They are definitely helping us. 300 million people are infected globally and many deaths did happen, though there is fudging of data to project the positive management of pandemic in different countries. USA provides potent demonstration of structural barriers Definitely, there is a lot of vaccine hesitancy. Even today, people are talking about 60% eligible people only received vaccine in a developed world like United States. So you can think of a developing world. Lack of access to vaccines is a challenging thing in developing world. So we have to understand all those things. Politically driven decisions are undermining health security. This is the one of the point highlighted in this article. So coming to the CDC released science brief on Omicron variant, as Sir has highlighted, November 24th, a red letter day, South Africa reported, I'm just using the terminology, South Africa has done a fantastic job in reporting the identification of this variant. And it was first detected in a lot of specimens. They were routinely conducting for surveillance on November 11th, followed by 14th. And since then, they did retrospectively a lot of sample screening, and it was found in the previous samples also. So immediately WHO entered into the picture. On November 26th, they named COVID-19 virus variant in South Africa and some other countries as Omicron, and it is classified as variant of concern. Till then, until today, 87 countries have been reporting Omicron variant in their population samples. And if you look at the timeline, December 1st, again, United States on World AIDS Day, they reported that the first client or customer who returned from South Africa, in his sample it was detected, followed by another person who had a reported history of international travel, attending a large symposium convention. He also was found to be thin. And across all these countries with robust tracking, surveillance, testing, and sequencing facilities, immediately jumped into the bandwagon, and all of them reported. Coming to the variant of concern, Sir has highlighted already the epidemiological data, which helps us to define a variant of concern, is increased number of infections. And also there may be concerning spike protein substitutions, some of which are known for other variants, but they are associated with reduced susceptibility to available variety of therapeutics and other detection modalities. So along with CDC, WHO, the European Center of Disease Prevention and Control, you might be wondering why suddenly I'm bringing European Center of Disease Prevention and Control. Right now, the Omicron is raging a battle in European part of the world. Norway, Denmark are pitched as the topmost countries, heavily burdened with the emerging numbers. So this particular European Center for Disease Prevention and Control also classified this as variant of concern regarding immune escape. That is what we just discussed. Potentially increased transmissibility compared to Delta variant. It's more like, as Sir said, we just will look into the data. Sir has projected this. It is Omicron, WHO label, Pango lineage, 21K next strain clade. Apart from all the elements Sir has already discussed, the spike protein displayed 30 plus, and yesterday it was 45 to 50 amino acid substitutions, deletions, insertions, whatnot. If we are a virologist, we can use them with command, and we will read that print, genetic print, which is evolving across the world. Notably, Sir has highlighted again receptor binding domain changes. All these things are of importance because when we talk about boosters, when we talk about fresh jabs, when we talk about diagnostic kits, these are the elements which will be going into development of that novel tools. If you look at this top 4 countries which are globally right now battling with the number of cases in Omicron, Denmark, today UK is classified as major incident. The mayor of London says that London is declared as major incident focus country, wherein they say like they may not be able to deliver the quality of services expected by the population because of Omicron affecting the healthcare workers, reduced staff availability in the hospitals, overloaded hospitals with hospitalization. So it is a major incident. The population cannot demand quality of services from the federal structure anymore, followed by Norway and South Africa. And if you look at the cumulative number of cases with variety of variants, Sir has listed starting from alpha, the green line shows exponential straight curve compared to the other varieties of curve you can see for alpha and other varieties, whereas Omicron green curve is showing straight shoot to the star kind of curve. So that helps us to explain why we should be worried. Though it is the number of cases, as Sir said, we hope It will not translate into hospitalizations and severity of infections, loading the health system. So we address this weary as we are, fatigued as we are, we can't afford to ignore Omicron. Complacency is the greatest danger in the fight against pandemic. In New York City, they are distributing masks and at-home testing kits right now. Right now, for new Christmas and other things, they are just doling out all these masks and at-home testing kits. The renewed fight against COVID. And let us compare what is the advantage or disadvantages when you think of Omicron with other variants, especially Delta. Delta is still raging in US. It is neck to neck competition between these two things. And if you look at the 4 indicators such as growth advantage, transmissibility, immune evasion, as well as infection severity, this is all the things for Omicron. Red, amber, red, the confidence level of evidence is high when it goes to growth advantage. Omicron is displaying a growth advantage over Delta. This is based on the data from UK. Increased household transmission risk. We talked about this when we interacted with our guest of honor, Dr. Kulandaswamy. So if you find a positive case, infected case in a family, it becomes extremely important. The household contacts are at increased transmission rates, increased secondary attack rates, substantially increased growth rates compared to Delta. So this is a point of interest for public health scientists and physicians in my department and whoever is listening. Please keep this in mind, and we need to keep contact tracing and keep this as a high index of suspicion. Coming to the transmissibility, it says like is at least as transmissible as Delta. So Delta itself is a high transmissibility. Wave 2, we have seen the huge blow it took in India. And right now, though this table is saying at least as transmissible, other data is showing that RO for this Omicron variant is 2.36. So we need to understand every 3 days it is doubling. So we need to understand, we have to be cautious about the emerging data. Immune evasion, we just discussed, it displays reduction in immune protection against infection. Okay, but there is no data regarding severe disease. So we need to be watching, we need to keep watching the data and signs emerging. Coming to the infection severity right now, because it is just emerging, November, December, hardly 3-4 weeks of data. In fact, insufficient data to talk about infection severity. But as Sir said in the morning, Denmark and Europe is actually gearing up for a different picture. So coming to the Indian status, the first case in India, the Omicron variety was first detected in India in Bangalore with 2 people testing positive who had a history of contact of travel from South Africa, and they are South African nationals. So that was the first case in India. Coming to the tracker, COVID live tracker, if you go online, you can see this data. I just kept a couple of cases for discussion and having an understanding how this travel history from South African origin, Zimbabwe and African countries helped us to quickly narrow down these cases in the beginning stages. But now, as I said, the virus is already inside our houses, our borders, or inside our geography. So we only implementing lockdowns and implementing travel restrictions at airports is going to slow down the pace of the progress of the virus, but it's already inside. So we need to keep that in mind. But if you look at this, the travel history is extremely important. All the cases which are being reported slowly, because Sir also addressed in the morning, symptoms transmissibility before the onset as well as transmissibility after the onset. In between, you are asymptomatic, you are coming in contact, you are being tested at the airport, you are producing a fake certificate. Yesterday in Tamil Nadu, Chennai airport or somewhere, a couple of people arriving from Hong Kong have produced fake RT-PCR test reports, and they are going through screening and they were caught. So all these dramas are being unfolding. So situation looks like a reality TV show. The coronavirus live track again in Andhra Pradesh, again foreign travel history. They were tested and found negative on arrival, but they were allowed to move forward on conducting second PCR. They are found positive. So this is exactly, I just wanted to re-emphasize the message which Sir also said earlier. One test negative does not ensure that you are negative, but if you are positive, you may ensure that you are positive, and you have to bring in all the other contacts into the testing loop. So the other hospitals which are being geared up, specialized hospitals in Delhi and everywhere, they are getting allocated again, similar to the wave 1 and wave 2. All infrastructure is upgraded for designated COVID care centers. So we need to be ramping up our facilities, infrastructure, testing capabilities, as well as therapeutic facilities for handling any kind of preparedness kind of mode. And coming back to the WHO, Omicron could spread faster, but it is still not certain. WHO always takes measured, cautious steps. And Dr. Michael Ryan, who is WHO's chief of emergencies, told that data about the variant so far is pointing to a virus that's efficiently transmitting, probably more efficiently transmitting by far, which is Delta and deadly version. So we need to be still focusing about transmission, but not talking about severity. And the ICMR test kit, which was flagged by Dr. Kannan in his presentation, among rising cases of variant Omicron, ICMR Dibrugarh, Assam Regional Medical Research Center, ICMR Assam, has designed a testing kit. The uniqueness of this test kit is it will be able to detect this variant virus in 2 hours turnaround time. This has been designed and developed indigenously by a hydrolysis probe real-time PCR assay. This is the technology they have harnessed in development of this kit. And this kit has been tested against specific synthetic gene fragments of the variant and within 2 differently highly specific unique regions of the spike protein, and with the reference of wild type control synthetic gene fragments. The reason I have put up this description in my presentation is we are also from Central Research Lab. It's not just a community medicine affiliation I'm projecting here. When we are talking from Central Research Lab on just flagging you, there is a test kit which is being released in India. We need to understand the dynamics here, and they're just talking about 2 different highly specific unique regions when you have like 30, 40, 50 mutations emerging. So we need to keep all these challenges and breakthrough infections, the challenges in testing and the challenges in inability to not detect, and those people going back with a false assurance that, oh, they tested and they found to be negative, and the fatigability and, the wearing effect, like, oh, we are fatigued with wearing this mask and subjecting to repeated testing. These all things model the human behavior. We can model virus, we can model diseases, but we are unable to model human behaviors. So coming back to the ICMR, the other kit which approves, we are talking about Assam kit, but there is another kit which is approved indigenously. This particular new kit, which is also talking about the same kit which is also talking about different variants. They are also talking about Delta lineage was the one which they targeted and started with, but they're hoping that the BA.2 lineage, which Dr. Kannan highlighted in his presentation, they added that a large percentage of their sequenced samples are recently from South Africa and all, but this COVID Delta kit, however, targets a downstream spike, and they think like this may also help detect other variants, not just Omicron, but some other variants like the earlier variants. And this is a new kit which IIT Delhi develops compared to the 2-hour earlier kit ICMR Dibrugarh. The IIT Delhi says that they developed a new kit which can detect Omicron variant in 90 minutes. So this is how innovation is happening in the middle of the pandemic. So the pandemic has not just scared us into apprehension and panic, but it also stirred up the minds of youngsters and entrepreneurs and scientists to fast track solutions, innovative, novel solutions. And the researchers from IIT Delhi Biological School of Sciences, they developed RT-PCR based assay for this specific variant. Can you just imagine, the variant emerged in November, and in December middle, you are talking about a new kit. That is how fast the innovation and entrepreneurship is happening in the middle of the pandemic. And this particular school of biological sciences, they developed this assay on detecting specific mutations, again present on Omicron variant. And this primer, they said, targeting the unique mutations on spike gene again, with specific amplification of either this variant or other circulating variants, tested using real-time PCR against synthetic DNA fragments and with a dynamic range of this many copies. So to conclude my presentation, the pandemic is over. That is what these bunch of buddies are talking. How do you figure? I have just had it, so that is that. Wish we had talked to him sooner. So this is the kind of mindset a lot of people are having right now, thinking that someone has experienced either a pandemic situation, whether they themselves or the family or the community they know has been affected with one variant, so they have surpassed that situation, so there is nothing to worry right now. That seems to be a misplaced confidence in the pandemic. The virus is proving challenging for us, but as I said, it is also opening up doors of avenues and opportunities for us to focus our efforts. And this is a right opportunity for us in India to focus how research can be enhanced, how collaboration can be enhanced, and how with the better appreciation of the science and the emerging variants and evolution of the virus, we can actually model better practices of human behavior and target this virus for better understanding as well as better prevention. So that is my presentation. What is the status in India? I did not want to overwhelm you with lots and lots of cases emerging because it's a real-time emergence of cases. As of today, 200 plus cases have been reported from India about Omicron variant, and all the states have enacted various measures for containment. Airport travel restrictions are there, large gathering restrictions are going to be in place. Already curfews are there till midnight in states of Maharashtra and big states like Delhi. People are discouraged to continue partying into late hours because of the festivities and Christmas and New Year's coming. So all this depends on the compliance of the population who are actually the beneficiaries of the policies, because we are the one ultimately going to be benefited if we practice these policies which are enacted for the benefit of public health. So with this background, I would like to once again conclude that the Omicron in India status is emerging. According to one scientist in Kolkata, according to the modeling data prediction, 1 lakh to 1.5 lakh cases are predicted to occur in the month of February. That is when the wave 3 is predicted to happen in India. And according to him, if we do not by then ramp up our mass vaccination rates across the country, which is still a little bit around 50 to 60%, and especially target the vulnerable population groups, as Dr. Vikram has highlighted in the morning, people above 65 years with comorbidities and also people with immunocompromised status who are staying in nursing homes and cancer therapeutic hospitals and all. If we can ensure coverage of all these vulnerable key populations as well as ensure all the eligible populations in the country complete their vaccination. When I say completion of vaccination, we are talking about 2 doses of vaccination. That is called vaccination complete status. And if we can ensure that all these personal protective, environmental, engineering and administrative plans and controls are in place at a holistic toolkit execution, then we can be ready to face the wave 3 pandemic. If at all it tries to kind of cover the entire pan-India, we will be in a very strong position to face it with this holistic approach. And the entire health system is gearing up for mega vaccination campaigns, and there is a positive surge of vaccinations post-Omicron scare in the public. That should be, as Kanan sir said, rather than forcing something on people doesn't work out in India. We have a lot of public health experiences in the past. Enforcing doesn't work. Rather than a participatory approach, taking them along with us, walking the talk, and with a good community involvement with participatory approaches such as involving community leader, religious leader, all kinds of community members, if they walk the talk, it will make a huge impact. Social engagement is important, and I hope Tagore Medical College and Department of Community Medicine will be able to lead this change in the communities we are serving in both Kelambakam and Krompet. And I hope to jump into this vaccination drive very soon after our webinar tomorrow, because we are seeing disappointment whenever we get a health camp data submitted from our health staff. So we will address that very soon. We will tackle this thing headlong and we will walk the talk. And I thank once again the Department of Central Research Lab and Pharmacology for collaborating with Department of Community Medicine in conducting this very timely webinar on overview of Omicron and oral antivirals today. Thank you so much for both the departments for collaborating with us. And with this, I will conclude my session. If there are any questions, I am happy to answer.
Dr. Sucharita, I would like to add some, again, information about the immune evasion. As you mentioned, just I want to throw light on it. See, it actually pertains to the immune evasion of the neutralizing antibody that is already present in our body. Okay, if I get a natural infection of COVID, or if I have taken vaccine, I will have the neutralizing antibody in the system. So when this Omicron enters, this may escape this neutralizing antibody. This is what we actually mean as immune evasion. Not that this virus, when it enters to a person like me, or not got so far the COVID infection, it evades the immune system. So definitely it is going to create the immunity in my body even if Omicron enters. The only point is that those people who already got COVID infection, they cannot be complacent, because this Omicron can cause infection even to the people who are already infected with this COVID. That is immune evasion. If you are vaccinated, or say I have got COVID, so I will not get Omicron. No. Omicron mutation are in such a way that it can escape from the neutralizing antibody. So vaccinated as well as the people who already got the infection should be careful as before. So they cannot be complacent. So not that a person who is going to be infected for the first time, the immunity is going to be poor or something. So just I want to add this. So why I'm again telling this, emphasizing this, because I have seen people who already got infection, they are very complacent, they never wear masks, they never have a social distancing or hand hygiene practice. So this Omicron is again going to be a new type of virus for these people also.
Thank you for that value added point, sir. You're extremely correct in pointing out that, because we are aware of this long COVID as well as breakthrough infections, right? So people receiving vaccines have been subsequently affected with the COVID, as well as people who already had COVID are unable to come out of it even for more than a year. Yesterday, I was attending a webinar where a healthcare provider, after receiving a vaccine, got a breakthrough infection, and it is forever running till now as a long COVID case. So as you said, the fatigue of administering all these vaccines plus PPE should not deter us from believing that the variant is emerging with new dimensions, and we should still, as Dr. Kodanaswamy sir said, universal work precautions is the way to go forward. Thank you so much for that highlighting point. Now I would like to move on to the next presentation. Schedule. I have a doubt. Who is having the doubt? Dr. Deepak, yes.
Ma'am, according to the popular belief and based on previous such pandemics, ma'am, it is said that when a new variant is very highly communicable, but when the symptoms are very low, it is said that it will lead to the end of a pandemic, ma'am.
Wonderful. If your words turn to be true, we'll throw a party for you.
That's what I want to know. Does it even hold true for the current pandemic, corona pandemic? That is my doubt.
Wonderful. So apart from mathematical predictions and modeling, we have a modeler and predictor in our department. See, please take appointment and come and meet Dr. Deepak Avinash, who is predicting the end of the pandemic. By what time, doctor?
That is my doubt, ma'am. Does this hold true for in this scenario also, ma'am?
Thank you so much. We are very hopeful by probably, as you said, very soon we'll be getting rid of this. And as Kannan sir said, more towards like a flu kind of mild respiratory infection, we can tolerate that and we'll move on with our lives. The business of living is much more important, and we will move on with that. Thank you so much.
Thank you. Thank you.
Yeah, now I would like to invite my young dynamic assistant professor in the department, Dr. A. Vikram. He's sharing a lot of new information about public health surveillance tools, protect yourself and others. He's been with the department for a very good considerable amount of time, and he's made a lot of good contributions in the department as well as for the college, as well as he's in charge of the Rural Health and Training Center. And he's actively involved in teaching and NAC meetings, as well as leading the postgraduate thesis guidance, as well as interns training. So I welcome Dr. Vikram to address the gathering about public health surveillance tools, protect yourself and others.
So thank you, madam, for your kind introduction. So good afternoon, everyone. So I will move on to my presentation. Please let me know whether screen. Please let me know whether it is visible to everyone.
Yes, yes, doctor. It is.
Okay, thank you. Yeah. So I will be just highlighting what the earlier speakers have spoken about Omicron. Because to understand the public health surveillance tools, so we need to know how this Omicron emerged and why it is designated as a variant of concern by WHO, and what are the strategies the WHO recommends for the member states to tackle all these variants. So it may be kind of repetition of the previous presentations. So I'll be just highlighting the important facts, but not going into detail with the description of this variant. As you are aware, Omicron is a new variant of SARS-CoV-2 virus that has recently been reported from South Africa on 24th November. And it is designated by Pango lineage as B.1.1.529. And as per the WHO nomenclature, it is designated as Omicron. So this particular variant has shown a very large number of mutations, especially more than 30 mutations on the viral spike protein. So this viral spike protein is the key target of immune response, especially by the vaccines. So the WHO declared this variant Omicron as a variant of concern on 26 November 2021. Following that, by November 30, the CDC, that is Center for Disease Control and Prevention of USA, they have designated this Omicron variant as a variant of concern. So as of 16 now December 2021, 89 countries from all over the world, that is from the 6 WHO regions, they have confirmed the presence of Omicron variant. So WHO designates the variants of viruses as variant of interest and variant of concern. So usually SARS-CoV-2 virus since January 2020. So during the late 2020, the emergence of variants that pose an increased risk to global public health. This prompted the WHO to categorize the variants as variant of interest and variant of concern. So we will see what is a variant of interest and what is a variant of concern by definition. And we will also see what are the currently designated variants of interest and variants of concern. So as per the definition of WHO, a variant of interest is a SARS-CoV-2 variant with genetic changes that are predicted or known to affect the virus characteristics, especially the transmissibility, disease severity, immune escape, and diagnostic or therapeutic escape. Along with this, a variant which is identified to cause significant community transmission in a country or multiple COVID clusters in different countries with increasing prevalence of the cases. If these two criteria are fulfilled, then a variant is called a variant of interest. At present, there are two variants of interest. One is the lambda, other one is the mu. So I'm not going to the detail of this Pango lineage. So the WHO nomenclature is a lambda variant which was designated as variant of interest on 14 June 2021, whereas the mu variant is designated as a variant of interest on 30th August 2021. So what the WHO does for a variant of interest? So what are the primary actions by WHO for a potential variant of interest? So first of all, they do a comparative assessment of variant characteristics and public health risk. A comparative assessment here means they compare the previous data on the infectivity of the virus. Then they compare the previous data with the present data of infectivity about the variant. And they also compare with different countries. For example, they have 6 WHO regions. So for each region, how the variant behaves. So those things are being compared by WHO. And if it is necessary, they also have a coordinated lab investigations with the countries which are currently reporting the variant of interest. And also the WHO reviews the global epidemiology of variant of interest. Okay, so how the agent, host, and environmental factors, how they act in different countries or different regions. So all these are being reviewed by the World Health Organization. And also the WHO, they monitor and track the global spread of variant of interest. So after monitoring and tracking of the global spread of variant of interest, and after reviewing the global epidemiology of variant of interest, this WHO, they can rename or redesignate the variant of interest as a variant of concern. So for this, they have to do global epidemiological studies of variant of interest and also monitor and track the global spread of this variant of interest. So coming to the actions that has to be taken by the WHO member states or those countries which are reporting a variant of interest, so they have to first of all inform the World Health Organization through established WHO country office or regional office. Okay. So especially they have to inform those information regarding the person, place, and time characteristics of the variant of interest, and also the clinical and other relevant characteristics of the variant of interest. Okay. For example, you can say a descriptive epidemiology and also the clinical profile of patients who get infected with this variant of interest. So those things have to be informed immediately to the WHO through the established country office or regional office. Then the country has to submit a complete genome sequence and associated data to a publicly available database. So for COVID-19, that is the SARS-CoV-2 virus, the WHO has designated this GAS8 as a database in which the genome sequences data are available. So GAS8 is nothing but a global initiative for sharing avian influenza data. Avian influenza data. So SARS-CoV-2 is believed to be an avian virus. So the GAS8 is the publicly available database in which the genome sequences data are being published. And the country or the member states in which the variant of interest are being confirmed, so they have to perform field investigations to improve the understanding of the potential impacts of the variant of interest on COVID-19 epidemiology, severity of the disease, effectiveness of the public health and social measures. So these field investigations have to be performed by the member states. And also the member states have to perform lab assessments according to capacity, or they can contact WHO for support to conduct lab assessments on the impact of the variant of interest on relevant topics. So how this variant of interest has what impact on the diagnosis or therapeutics. So those things have to be carried out. Those assessments have to be carried out by the member states reporting the variant of interest. So coming to the variant of concern. So the WHO defines a SARS-CoV-2 variant as a variant of concern when it meets the definition of variant of interest. That is, it has to have a genetic changes which are predicted or known to cause some changes in the virus characteristics. Along with that, there should be evidence of community transmission or multiple clusters in multiple countries. So this is the definition of variant of interest. So that has to be first fulfilled by a SARS variant. Along with this, they have to have the following changes like increase in transmissibility or some change in the COVID-19 epidemiology. Especially, it should be a detrimental change in COVID-19 epidemiology. That is a change which is drastic in the agent, host, and environmental characteristics of the infectious agent, along with increase in virulence. That is increase in the infectivity or virulence or killing power, or change in the clinical disease presentation. That is any drastic change in the clinical disease presentation compared to the previous variants, and decrease in the effectiveness of public health and social measures. So the available social measures and public health measures which prevent the disease transmission, so they are not effective against the new variant. So if all these things are fulfilled, then a variant is considered as a variant of concern. So here they have to meet the definition of variant of interest. Along with that, there should be a documented evidence of increase in transmissibility or detrimental change in COVID-19 epidemiology, increase in virulence or change in clinical disease presentation. Along with that, decrease in the effectiveness of public health measures and available vaccines, diagnostics, and therapeutics. So this is the definition of variant of concern. So the currently designated variants of concern are 5. The first one is alpha, which was designated as variant of concern on 18 December 2020, followed by beta, which was designated on 18 December 2020. Followed by this, we have gamma delta variant. So at present, delta variant is the dominant variant in most of the countries that are reporting current present infections of COVID-19. So the fifth variant, that is the recent or latest variant of concern, is the Omicron variant, which was designated as a variant of concern on 26 November 2021. So this Omicron variant is expected to surpass the Delta variant as the dominant variant in the coming infection of COVID. That is the future infection of COVID-19 in the world. So what are the primary actions that the WHO take for a potential variant of concern? So as usual, they have to do a comparative assessment of the variant characteristics and public health risk, along with the technical advisory group on virus evolution. So this technical advisory group on virus evolution, they track the evolution of viruses, especially the SARS-CoV-2 virus, and they are the people who engage in this classification of viruses, variant of concern, variant of interest. So whenever a potential variant of concern is being confirmed in any part of the world, then WHO has to do a comparative assessment of the variant characteristics. Followed by it, they have to do lab investigations along with the member states and their partners. If they get to know something new, then they have to communicate the new designations and the findings which they get to know from the comparative assessment to the member states in which the variant of concern is being reported. And also the WHO has to evaluate their guidance through established mechanisms and update if necessary. So based on this comparative assessment and other findings, they have to communicate the new findings to the member states which are reporting variant of concern. Along with that, the WHO will also modify their guidance and update them based on the current findings. So this is the primary action that will be taken by the WHO for a potential variant of concern. So coming to the actions that have to be taken by the member states reporting the variant of concern. First of all, they have to submit a complete genome sequence report and data to a publicly available database like GIS-AID. They have to also report initial cases or initial clusters associated with the variant of concern infection to WHO through international health regulation mechanisms. That is through IHR mechanism, they have to report the initial cases and clusters. And wherever the capacity exists, and in coordination with the international community, the member states or the countries reporting variant of concern, they have to perform field investigations and lab assessments to improve the understanding of the potential impact of this new variant on COVID-19 epidemiology, severity, immune escape, diagnostic or therapeutic escape, and effectiveness of the presently available public health and social measures. So on all these topics, a field investigation and lab assessments have to be done by the member state. So the WHO declared this Omicron variant as a variant of concern on 26 November 2021 based on this above criteria, that is based on documented evidence of increase in transmissibility or detrimental change in COVID-19 epidemiology, increase in virulence, change in clinical disease presentation, or decrease in effectiveness of public health and social measures. So based on their assessment of this variant on all these parameters, they declared Omicron as a variant of concern. So coming to threats posed by Omicron, so 4 key questions are there in order which has to be answered when we talk about the threat posed by Omicron. First is how transmissible the variant is. That is how transmissible the variant is compared to the other variants, especially the Delta variant, which is the dominant variant at present all over the world. Then how well the vaccines we have received already, or those with prior infections, they have some immunity. So whether these protect against the infection with Omicron, or is there any change in the clinical disease or severity? So this has to be answered. And how virulent this variant is compared to other variants, especially the Delta variant. So what is the virulence of this variant in comparison to other variants of concern? And also how populations understand these dynamics, that is the disease dynamics, how the population, what understanding they have on this disease dynamic, along with how they perceive the risk and whether they are willing to follow the control measures, including the public health and social measures. Because already we are into the second year of the COVID-19 pandemic all over the world, so people are already having this COVID fatigue. So if we are telling about a new variant which poses a risk for their health, so whether they are going to comply with these things or they are going to avoid because of this fatigue. So all these questions have to be answered when we talk about the threat posed by Omicron. So coming to the transmissibility, as Sucharita madam has already talked about the characteristics of this new variant on transmissibility, clinical severity and diagnostics. So I'll just throw some light again on these topics. So coming to the transmissibility of this Omicron variant, this Omicron variant has shown rapid spreading, which is faster than Delta variant, with a doubling time between 1.5 to 3 days. And it also spreads rapidly in countries with high levels of population immunity. And it remains still uncertain to what extent the observed rapid growth rate can be attributed to immune evasion, increased transmissibility, or a combination of both, because still we don't have enough data to comment on all these things. But with this current, given the currently available data, we can only say that Omicron will outpace the Delta variant, where the Omicron will be a dominant variant all over the world in the coming 1 or 2 months, as per the mathematical models used to expect the surge in cases. So we can only say that Omicron will outpace Delta variant in countries where the community transmission occurs. Coming to the clinical severity, so the data on case severity, including this hospitalization, need for oxygen or mechanical ventilation or deaths, they are still limited. We don't have enough data to comment on this. But the data available from the countries like South Africa and UK, we can only say that both the countries have seen a rapid increase in the incidence of hospitalizations in both public and private health sectors. Especially in United Kingdom, they have seen a rise in cases with confirmed SGTF, that is the S gene target failure, which mostly point towards the Omicron. So those cases, they have increased in all the regions of United Kingdom since the end of November. One more thing is, most of the patients who reported had either mild symptoms or were asymptomatic. So even though this early data suggests that the severity may be potentially lower than the Delta variant, but if the cases rise rapidly, then it will be an overwhelming situation for the whole hospital settings. So this more number of hospitalizations will again put a burden on the health system. Coming to the diagnostics, the diagnostic accuracy of routinely used PCR techniques and antigen-based rapid diagnostic test kits, they do not appear to be affected by Omicron. But most Omicron variant sequences reported, they include a deletion in the S gene, so which can cause this SGTF, that is S gene target failure in some PCR assays. So whenever we get a S gene target failure in PCR, we can just point towards the Omicron variant, which can be used as a proxy marker to screen for Omicron. But the confirmation of this Omicron has to be done by genomic sequencing, because this deletion, that is S gene deletion, can be vaccines and previous infection. So as per the available data, there is a reduction in neutralizing titers against Omicron in those who have received a primary vaccination series or in those who have had a prior SARS-CoV-2 infection. So that is, this suggests a level of humoral immune evasion, that is the antibodies. So this Omicron variant usually escapes the antibodies, So coming to the actions recommended by WHO to tackle the Omicron. So what the member states have to do. So first of all, they have to enhance their surveillance. So they should, all the member states which are reporting the Omicron variant have to ensure early warning systems are in place, which is composed of multiple indicators such as growth, that is growth rate and effective reproduction number of the variant, and case incidence and test positivity proportion. So they have to monitor all these indicators. And also they have to monitor indicators related to disease severity and pressure on healthcare systems, like the bed occupancy rate for both general ward and also intensive care units, along with that healthcare worker exposure and also the burnout among healthcare people. So these indicators have also to be monitored regularly as a part of this enhanced surveillance. The member states should also have to perform studies to improve their understanding of transmission parameters and vaccine effectiveness, severity of the disease, effectiveness of public health and social measures against Omicron. So there are two types of studies. First is the field surveys to know the population risk perception, how the population they perceive the risk. So they have to be known by field surveys. Along with that, you should also know the knowledge, attitude, and behavior towards the presently or currently available public health and social measures, vaccines, and tests. Coming to the lab studies which have to be performed by the member states, so they have to point towards the diagnostic methods, whether they are really effective in diagnosing the new variant, and also the immune responses, whether the humoral immune response and cell-mediated immune response are intact against the Omicron variant, and also they should know the antibody neutralization, whether the neutralization by antibodies have reduced or they have increased. So those kind of studies have to be taken or performed by the member states reporting this Omicron variant. And these epidemiological studies and sequencing of specimens, they have to be targeted to those people with particular characteristics, like those who had suspected reinfections or those who have any different clinical characteristics or immunocompromised patients, and those people who had a selective sequencing of vaccine breakthrough. So all these people, they have to be targeted for this epidemiological studies to know the impact of this variant on the previous prior infection and vaccination. And also, while recording the case data, particular attention has to be paid to the cases vaccination status, because we are not clear about the protective level of vaccines against the reinfection by Omicron. So we should collect data on the cases vaccination status, and also what kind of vaccine product did they receive, and also the dates particularly they have to mention, because to know how long the vaccine is protective against Omicron variant. And also we should know or get the data about the history of previous SARS-CoV-2 infection and the symptoms, as usual, the clinical profile of the patients to know the clinical severity or outcome. To assess whether Omicron have already been circulating in the past. So to know whether the Omicron has been circulating in the past in the countries, so what the country have to do is they have to conduct a retrospective review of the available genomic sequences and S-gene target failure data from October 2021 onwards to find out the presence of previously circulating Omicron variant in the country. So to enhance the prospective detection of Omicron, that is those countries who have not yet detected any Omicron variant specimen, so they should monitor Omicron introduction through targeted sequencing of suspected Omicron cases. Here what they have to do is those Omicron cases like which have tested SGTF, that is S-gene target failure cases, they have to be sequenced, that is the genomic sequence has to be applied on those specimens to find out Omicron introduction in those countries which have not yet reported any case. And also they have to detect Omicron community transmission through random sampling among SARS-CoV-2 confirmed cases in the community. So these countries have to do two things. One is they have to monitor the Omicron introduction through targeted sequencing of suspected Omicron cases. So whenever they suspect Omicron cases, they have to do targeted sequencing for finding out the Omicron. And also to detect Omicron in the community, they have to do a random sampling survey among the SARS-CoV-2 confirmed cases to find out whether the Omicron has been reported or not. So those countries in which there is already community transmission of Omicron, they have to reconfirm this by again doing the random sampling or sequencing among confirmed cases. So all those countries which are doing such type of field studies, they have to report the numerator and denominator of Omicron samples detected in order to allow the calculation for prevalence of circulating Omicron variant. So at each country level, we need to know the prevalence of this new variant. So in order to know that, we need both the numerator and denominator of this Omicron samples. So this is the part of enhanced surveillance which is recommended by WHO. So coming to the lab testing for Omicron, so all the suspected and probable cases of Omicron infection should be confirmed by genomic sequencing. So both target sequencing of the spike gene, that is sequencing for the deletion of this spike gene in, that is the sequence target sequencing, and also whole genome sequencing. Both these things are being approved as appropriate to confirm the presence of Omicron. And also the national testing capacity and genomic sequencing capabilities, they have to be appropriately planned for possible surges in testing demand for community and international travelers. So for a country like India, we have reported almost something around 1,000 cases of Omicron. So what the WHO states is that all those countries which are at present reporting confirmed cases of Omicron, they have to increase their national testing capacity and also national capacity for this genomic sequencing capabilities. They both have to be increased in order to address the upcoming need for or upcoming demand in testing for this community transmission, because the community transmission of Omicron has not yet occurred in our country. So we have to enhance the national testing capacity. Coming to vaccination, so the WHO recommends that all member states which are reporting this Omicron variant of concern, they have to accelerate their COVID-19 vaccination coverage in all eligible populations, with priority to those population at high risk for developing serious disease or serious complications. So those high risk population includes the elderly people and healthcare workers and those with underlying conditions putting them at risk of severe disease. For example, those with comorbidities like diabetes or cardiovascular diseases, and also those people who remain unvaccinated, they have to be put on priority while vaccinating. So this Omicron have reported a high likelihood of immune evasion, especially from this humoral immunity, that is antibody mediated protection. So with this thing, we cannot stop people from getting vaccinated. So despite all these uncertainties, we can say that, or we can believe that it's still reasonable that currently available vaccines, they definitely give some protection against the Omicron, especially against the severe disease or death. So the main aim of vaccination is to prevent severe disease and death in individuals. So vaccination coverage has to be accelerated in all the countries. So coming to the approach to international travel, so WHO states that the national authorities can apply a multi-layered risk mitigation approach to potentially delay the exportation or importation of a new variant. For example, by entry or exit screening of individuals who travel from country to country, and testing of the individuals for this Omicron variant, and quarantine of travelers. And if the people they get tested positive, then they have to be isolated in a health facility. So such kind of risk mitigation approach for international travel can be carried out by the national authorities. And also it advises all travelers that they should remain vigilant for the signs and symptoms of COVID-19, and they should get vaccinated appropriately when it is their turn, and they should also adhere to the public health and social measures at all times. As far as this travel ban is concerned, this WHO has not told the countries to ban travel as a whole, because international travel will again, what happens, it has an effect on the economy of the country. So if it has a negative effect on the economy of the country, the country will not come, the countries will not come to forward to report the cases. So it will actually demotivate the country. So that's why WHO does not recommend international travel ban. So coming to the public health measures, as usual, this use of a well-fitted mask whenever people go into crowded places, or using of the mask in wearing a mask in workplace, along with social distancing of 6 feet and adequate ventilation of the indoor space, and avoiding crowded places and following hand hygiene. That is frequent hand washing with soap and water or using alcohol sanitizer. These things remain the key in reducing transmission of COVID infections. And the use of established public health measures in response to individual cases or cluster of cases like contact tracing and quarantine and isolation, they must also be continued for this Omicron variant also. And we should also involve the community leaders or civil society or community-based organizations which have an influence on the people to understand the impacts of these public health measures. And these people, they have to be involved. That is the community leaders and civil society organizations, they have to be involved in promoting the public health and social measures in prevention of this COVID-19 among different population groups. And the WHO also recommends all the member states to be ready with their healthcare system, because in anticipation of the possible increase in COVID-19 caseload because of this Omicron variant, so it recommends all the countries or advises them to ensure mitigation plans are in place to maintain essential health services, and also that necessary resources are in place to respond to the potential surge. So that is, people have to have the countries have to have a track on their essential health services availability and also the necessary resources, especially the health resources. They have to be in place to respond to the future potential surge in the COVID-19 caseload. Coming to the risk communication and community engagement. So it is mandatory, or it is a duty of the national authorities to communicate the information related to Omicron and their potential complications to the public in a timely and transparent manner without hiding anything. They have to be communicated to the public. And listening to community perceptions, that is, different people or different population group, they have their own perception regarding the vaccines, and also they have their own perception regarding the new variant, especially because of this pandemic fatigue. So the country or the national authorities, they have to listen to the community perceptions, which can be through online or offline methods or social behavioral surveys, and they have to analyze this data in order to respond to the community perceptions and to have an effective communication and engagement interventions. Apart from this, the COVID-19 information overload should also be managed by the national authorities by providing the right information about the variant at the right time and to the right people through trusted channels. So this is the most important thing. So this has to be ensured by the national authorities. That is, they should provide the right information regarding this new variant at the right time and through a trusted channel. That is, those channels which are being trusted by the people, like community or faith leaders, family doctors, or other influential members of the society. So coming to the public health surveillance in India, especially for this Omicron variant, what the government has done. First of all, they have started the testing of international travelers arriving at airport, seaport, and land port for COVID-19. So they have given a set of guidelines for testing these international travelers at these ports of entry to the country in order to have a track on the Omicron cases in the country. The next thing is they have emphasized on the genomic sequencing to identify the Omicron variants. That is, those people who test negative, that is, those who test for this SGT, that is, S gene target failure. So they have, those specimens have to undergo genomic sequencing at nationalized laboratories or standardized laboratories to identify the Omicron variants in the country. And contact tracing of the COVID-19 tested positive patients, especially those people who are tested positive for this Omicron variant. So their contacts have to be traced and they have to be either quarantined or isolated based on their test result. Then strict implementation of quarantine and isolation, quarantine of the contacts and also isolation of the cases. So that have to be strictly implemented. So these are the public health surveillance measures which are being taken by the government of India with respect to this Omicron variant. The coming to the initiatives taken by the government of Tamil Nadu. So the Tamil Nadu government has prioritized specimens with S gene target failure for sequence confirmation, and they have also introduced this thermotag-path RT-PCR kits with SN and ORF targets. They are being supplied to all the government labs and they are being used for sequencing samples. and any sample with S gene target failure in the recent past. That is, they have defined the recent past at the time from 15th October 2021 to till date. These samples, they have to be referred immediately to the state public health laboratory for sequencing confirmation of Omicron variant. And those positive samples reported by private RT-PCR labs during this period, that is from 15th October to till date, they have to be cross-checked for this. They have to be cross-checked for this S gene target failure, and they should be sent to for genomic sequencing to the state public health laboratory. And also, the Tamil Nadu government have issued guidelines for all foreign travelers who have tested positive for COVID-19. They have to be subjected to genomic sequencing for identifying the Omicron variant. So these are the initiatives taken by the government of Tamil Nadu with respect to this Omicron variant. So coming to how to protect ourselves from the others. So how to protect ourselves? Simple thing is we have to follow this COVID-19 appropriate behavior. So this COVID-19 appropriate behavior is a set of 15 principles which have to be followed in order to prevent the spread of infection. So first thing is we have to greet without physical contact. Second thing is we should maintain physical distancing. And third thing is we should wear reusable mask or handmade face cover at all times. And we should avoid touching our eyes, nose, and mouth. We should maintain respiratory hygiene. We should wash hands frequently and thoroughly. And we should regularly clean and disinfect the frequently touched surfaces. And we should avoid spitting in the open. We should avoid unnecessary travel. And we should not discriminate against anyone. And we should discourage crowd and encourage safety. Apart from this, we should also do not circulate any social media posts which carry unverified or negative information. And we should always seek information on COVID-19 from credible sources. We have this national toll-free helpline 1075 or state helpline numbers for any queries regarding this COVID-19. And also we should seek psychosocial support for any stress or anxiety. So we'll be looking into all these things one by one. The first one is greet without physical contact. So it is always better not to give shake hands. So that's why in Tamil culture we always say vanakkam with the both hands combined like this. So that is greet without physical contact. We should follow this thing. Apart from this thing, we have to maintain physical distance. So the government has told so physical distance of at least 6 feet between two people. So it decreases the transmission of the risk of transmission of this COVID infection. So we have to maintain a physical distance. Always when we go to a crowded place or indoor places, we have to maintain the physical distance. And we should wear a face cover, that is handmade face cover or mask at all times. So most of us, we might have seen people, the public, they don't know how to wear a mask. So they may not cover their nose, or at times they cover only their mandible. They won't cover their mouth, or they don't cover their nose. So these are the simple guidelines on how to wear a mask. So first of all, before wearing a mask, we should wash our hands thoroughly with soap and water. Or if you don't have this soap and water, we can go for a alcohol hand sanitizer. So we should always wear mask so the nasal clip is over the nose, and external pleats should face downwards. So we should open the mask pleats so it covers the whole mouth and nose. Then the upper strings have to be tied first, then the lower strings, and there should not be any gap between the face and mask while using the mask. And we should not touch the front of the mask. While removing the mask, we have to remove by first untying the lower string followed by upper string. And usually it is better to replace the mask after 8 hours or when the mask becomes damp or humid. So we might have seen people not replacing their mask for even days. So it's always better to replace the mask after 8 hours or when damp or humid. So dispose the mask in a recommended manner. That is, they have to be disposed in the recommended manner. And we have to clean the hands after removal of the mask. And it is better not to reuse the single-use mask. So these are the 3 essential situations when wearing a mask is always compulsory. So when we undertake any essential travel or go to any public place, so we should always wear the mask. Then when we are in a room with other people, especially in the workplace where people will be sitting in a cabin, the 3-4 people, so that time we should always wear mask to avoid the risk of infection. And when you have any signs of cough, cold or flu, then we should always wear a mask. So these are the 3 essential situations when we should always wear a mask. Then we should also avoid touching our eyes, nose and mouth. Why? Because usually our hands, it touches different surfaces which can be contaminated with this COVID virus. So after touching this, if we touch our eyes, nose or mouth, then the risk of infection is highly likely. So it is better to avoid touching the nose, eyes and mouth with the hands. And we should always maintain respiratory hygiene. So respiratory hygiene is we should always cover the nose and mouth while sneezing or coughing. Either use a tissue paper or a handkerchief. When there is no handkerchief or tissue paper, then we can use the bent elbow for covering the mouth and nose while sneezing and coughing. So it is always better to wash the hands after coughing or sneezing. So this is the respiratory hygiene and it has to be maintained at all times. Then we should have wash our hands regularly and thoroughly using soap and water. So if there is no soap and water, we can go for this alcohol-based hand sanitizers. And we should regularly clean and disinfect frequently touched surfaces by using a disinfectant so that those surfaces which are contaminated by the virus, they can be disinfected. So for that, we need to regularly disinfect the frequently touched surfaces. And we should always not spit in the open. So as per Indian law, the spitting in open places is an offense. So it's not advisable to spit in the open spaces because it increases the risk of COVID infection. So we should always restrain ourselves from spitting in the open places. And also we should avoid unnecessary travel to other countries or other places where COVID transmission is there. Then we should not discriminate against anyone. So we should always show compassion and support the persons affected with COVID-19 and their families. We should not discriminate them. And we should also boost the morale of doctors, nurses, police, and sanitation workers who are on guard 24/7 to protect us. Because if we discriminate against people who have COVID, then people will not come forward to report their signs and symptoms and they may not get treated. Because coming forward to report the symptoms and signs and getting treated itself is a move towards the elimination or eradicate or the control of this disease spread. So that has to be encouraged. So we should not discriminate people against this COVID infection. And we should also discourage crowd and encourage safety. So we should avoid going into crowded places. And if there is some important event which cannot be postponed, then we should always keep the number of guests to a minimal amount. And we should not circulate any social media posts which carry unverified or negative information. So without checking the credibility of information, we should not simply be forwarding any information regarding the new variant or COVID-19 to all our contacts. So it's better not to circulate social media posts which carry unverified information. And we should always seek information on COVID-19 from credible sources. So usually we have our Ministry of Health and Family Welfare website from which we can get information on COVID-19. Along with that, we have our tnhealth.org, which is the state government's website from which we can get credible information on COVID-19. So whenever we have some queries regarding COVID-19, we can always call the toll-free helpline number, which is 1075, and also we have state helpline numbers for getting our queries answered. And also we should seek psychosocial support in case of any distress or anxiety, because whenever there is a pandemic, it is usual for people to have some stress or anxiety about the infection and disease. So it is always better to seek psychosocial support, because whenever we go into some distress or anxiety, our immune system will also have some influence by this anxiety or distress, which reduces our immunity. So it is better to seek psychosocial support in case if somebody has any distress or anxiety. So the government has given a national psychosocial toll-free helpline number, so in which we can call and get our queries answered. So with this, I conclude my presentation. Thank you everyone for the patient listening.
Yeah. Thank you, Dr. Vikram. That was a very informative session with a lot of pictorial infographics, especially the last toll-free numbers and the pictorial way of educating us about the COVID appropriate behaviors and recommended methods of wearing masks. I think I would request you to take the help of postgraduates in the department and develop the infographic kind of handouts which we can distribute in the health camps.
Yes, madam. Sure,
because
madam.
they are so self-explanatory We don't even need to explain to them. If we can print out those pamphlets with the help of stores after getting permission from Dean Madam about correct way of wearing masks and disposing, as well as social distancing, not greeting. I think this is the real need of the hour when we are expecting the new variant spreading so widely, and transmissibility being 3 times more than the Delta. I think if you can do the job of collating the necessary pictorial things and putting up a set of pictorial pamphlets, which we will request the stores to print out, all the health camps which we are going for rural and urban centers, we can distribute to our population.
Yes, ma'am. Sure, ma'am. I will do that.
And your slides also addressing risk communication and behavioral change, they're very appropriate, highly necessary in the context of vaccine hesitancy and COVID fatigue. So we need to emphasize the message repeatedly, and your pictorial pamphlet distribution and talking to them during our door-to-door campaign by interns, as well as household survey. These handouts will be extremely helpful.
Yes, ma'am. Sure, ma'am. I will do that.
Thank you so much. You have taken, your efforts are visibly seen in the presentation. You have taken great efforts in putting together that wealth of information. I sincerely thank you, but more than that, I commend your job. It's an excellent job
Yes, ma'am.
putting together that much wealth of information about public health surveillance tools, as well as how to protect yourself and others. Thank you so much for
Thank
that
you.
wonderful session.
Thank you, ma'am.
As we are already exceeded 10 minutes, I would rather request the students to post the questions, our audience to post the questions in the chat box, and we will take up the questions towards the end. Now we will proceed and take the lunch break, and we will reconvene again at 1:40, so that Professor HOD of the Department of Pharmacology, Dr. Geeta, will address us about what is the current scenario regarding oral antivirals to tackle the variant of concern, Omicron. So let us all break for lunch for half an hour. Thank you so much.
Thank you, ma'am.
Welcome back to one and all. We are happy to restart our afternoon session. After a day-long deliberations discussing deeply about Omicron and its impact on global level at national level, now we are moving on towards the afternoon scheduled program. We have a featured session from Professor and HOD of Pharmacology Department, Professor Dr. R. Geeta. All of us who are working in this college are aware of the contributions made by Dr. Geeta, especially related to research area. She's been head of the Institutional Ethics Committee, and she was instrumental in Tagore Medical College receiving the recent NABH accredited clinical trials approval. And for a long time, she has been spearheading the research efforts for ICMR STS projects at undergraduate level for postgraduate thesis, as well as all the faculty related research projects. She is instrumental in getting them approved by ethics committee in a systematic manner. And today we are fortunate to collaborate with the Department of Pharmacology in conducting this webinar. And now I welcome Professor Dr. R. Geeta to deliver her session on Omicron and oral antivirals, an overview. I understand that she's going to handle a very interesting topic because everyone is looking towards both preventive and therapeutic angle of COVID-19. And entire morning session we have talked about behavioral aspects and preventive aspects. Now we are deep diving into therapeutics. So without much further delay, I invite Dr. R. Geeta to deliver her session. Welcome, madam.
Good afternoon. Good afternoon. I would like to thank Dr. Sucharita and Dr. Kannan for giving me this opportunity to be a part of this wonderful session since morning. We had a very good session. As you said, the preventive and therapeutic, both are important. So I'm happy to be a part of this. So let me, without any further delay, let me start my presentation. My slide is visible.
Yes, it is visible, Dr. Geeta. Can you move to slideshow?
Is it slideshow now?
Yes, it is going to be, I believe.
Okay. So since morning we have been listening to in detail about SARS-CoV-2, severe acute respiratory syndrome, coronavirus 2, and we all by now we are expert in it, isn't it? So it is a strain of coronavirus which causes coronavirus disease, and we also know that this is a disease which started in December 19 in China. That is why the name COVID-19 is there. And the pandemic somewhere started in March 2020, and the lockdown began, and we know what we all have been going through. Okay, and it, one of the reasons for the chaotic situation was that no specific treatment was there at the beginning of this pandemic. So at that particular time, what was done was that since no specific treatment was there, they went on to use drugs which was already available. That is the repurposing of the drugs, and they tried to find out which was effective against this particular virus. And also in the meantime, they developed the newer drugs also, and we have presently we have vaccines also available, isn't it? So before I go, yes, you have seen the life cycle, you are experts in that. So, but I would like to say a few things. I will also tell you the reason why I want to show you all this all over again. So SARS-CoV-2 is a beta coronavirus which belongs to coronavirus family. Yes, we know that. And also it is a single-stranded RNA virus, and it has got 4 structural proteins. One is a spike, another is the envelope, membrane, and nucleocapsid. Okay, and Kannan beautifully showed one diagram in which you were able to see all these parts. Now, if you can see this one, nicely they have labeled it to 1, 2, 3, and 4. Okay, and here is the 5th one. Now, the SARS-CoV-2 attachment to the host cells is it is initiated by interaction between the SS protein and its receptor. What is the receptor? It is the angiotensin converting enzyme 2 receptor, ACE2 receptor, and after the binding, an acid-dependent cleavage of S protein by type 2 transmembrane serine protease happens, and this is followed by fusion of the viral and the host cellular membrane. What will happen because of this fusion? It enables the virus to gain access to the cell cytosol. Okay, and inside the host cell, the viral polyproteins are synthesized and further encode the replicase transcriptase process. Okay, now the virus, by utilizing the RNA dependent RNA polymerase, the virus will synthesize its own RNA. Okay, structural proteins are then getting synthesized, and this is followed by assembly and release of the new viral particles. Okay, so this one you have spike protein of virion binds to the receptor. Then in the second one there is internalization of virion and RNA release. Then third, what is happening here? Replication of viral RNA and translation of viral protein. Okay. Fourth, what is happening here? Proteins and RNAs are assembled into new virion. Okay, and then the new virion gets released. As you have been listening to the life cycle, but why am I telling you all these things? Because when we are talking about treatment, the drug should be something which should target a specific area so that the virus can be killed or controlled. Yes, sir, isn't it? So an antiviral drug, that is what we are going to see in this session. Antiviral drug must be able to target the specific part of virus life cycle which is necessary for the reproduction of the virus. We have to target wherever the reproduction is happening. We have to target that particular area. To know where to target, you have to know the life cycle of the virus. That is the reason why I have to repeat it again. Also, the antiviral drug must be able to kill a virus without killing the human cell it occupies. Isn't it? We all know we also know that any issues? I can hear lots of voices. Okay, we'll continue. The viruses are highly adaptive, okay, and also they are able to produce rapidly. They are able to mutate, and because of this particular characteristics, they become resistant to whatever drugs or vaccines you are trying to bring. So since we know all these things, we need to give the therapy early in the course of the COVID-19 so that we can control the progress of the disease, rather allow it to become critical. Okay, so as I said in the beginning, at the beginning of the pandemic, we didn't know what therapy to use. So a lot of drugs was repurposed. Not only antiviral drugs, there were other drugs which was used for some other purpose, but was able to control the virus. So that was also being used, like you can see here, chloroquine, hydroxychloroquine, and all. Okay, so here I'm going to tell you drugs which is able to inhibit the virus. Okay, these are the drugs which are approved, under evaluation, and also under evaluation, and these are the drugs which are directly not only useful in inhibiting the virus. There are other drugs also which was used for other purposes also, which was used for inhibiting this particular virus. Okay, so let us start with the antivirals which can be used and how it will be useful. The drugs which you are going to see are the ones which is able to inhibit the viral entry via the One is the inhibiting the receptor, angiotensin converting enzyme to receptor, and transmembrane serine protease 2. Also, you will be seeing drugs which inhibits the viral membrane fusion and endocytosis. Those also drugs you have certain drugs which inhibits the activity of SARS-CoV-2 free chymotrypsin-like protease, and then you have drugs which inhibits RNA-dependent RNA polymerase. So we are going to see which are the drugs which is able to do all these things. So let's start with the first drug, which is remdesivir. We all know it is a nucleotide prodrug of an adenosine analog. Okay. And when it is given, it is metabolized into its active form, nucleoside triphosphate by the host. So it is a prodrug which gets activated after it is being given. Okay. So how is it useful? What does it do? So when it is given, it binds to the viral RNA dependent RNA polymerase, and it's able to inhibit the viral replication by terminating the RNA transcription prematurely. Okay, so you have to recollect what Kannan sir taught you, all the structural parts, and also to correlate what is being told to you now. So it binds to the viral RNA dependent RNA polymerase and inhibits viral replication by terminating the RNA transcription prematurely. Okay, so this particular drug, it was known showed in vitro activity against SARS-CoV-2. Okay, and also they did a lot of studies in animal models where the disease was created, and they found that the remdesivir treatment was initiated when the treatment was started. The animals who are treated with remdesivir, they have lower virus levels in the lungs as compared to the control animals. So this particular drug was used for the treatment of COVID-19, and presently this is the approved drug by the FDA for the treatment of COVID-19 in hospitalized adult and pediatric patients. When I say pediatric patients, it is children who are more than 12 years age, who weigh more than 40 kg, but it is not for less than 12 years. So as this is a disease which the virus just keeps on mutating, right? So we have to bring out therapies and drugs according to the current situation. So currently, this is the drug which is approved by the FDA for the treatment of COVID-19. Please keep it in mind, this hospitalized patient. It has to be given in a hospital care. There are certain adverse effects which was noticed certain serious ones was it was causing elevated transaminase levels, increased prothrombin time, and also hypersensitivity reaction. So definitely we need to do certain tests while the patient is receiving the drug, like liver function test, prothrombin test, and you have to repeat these tests during the treatment also as and when indicated. Okay. And when it came to special populations, like I said, in children less than 12 years, we do not have enough data for them to be prescribed to the children, and a lot of clinical trials are being done with this drug. Then only they came to this conclusion that it can be given for certain set of populations. Like one of the trials was the adaptive COVID-19 treatment trial, ACTT1 trial, and they came to this conclusion that in patients with severe COVID-19, it was able to reduce the time to clinical recovery, and the benefit was most apparent in hospitalized patients who were receiving supplemental oxygen. Can you keep this in mind? It was not observed, no observed benefit was seen in those with high flow oxygen in cases of non-invasive ventilation, mechanical ventilation, and all. Okay. So that is one thing. All the trials which was done, there were certain limitations, there were certain conclusions also. Other trials which was done with remdesivir was one was the discovery trial. Okay, this was done with patients, hospitalized patients with moderate or severe COVID-19. This was done in Europe. Here they found out that there was no benefit of this particular drug in hospitalized patients who were symptomatic for more than 7 days, who required supplemental oxygen. And then another trial like WHO Solidarity trial. Here also it did not decrease in hospital mortality or the need for mechanical ventilation as compared to standard treatment. Okay, so remdesivir was kind of trials are going on. Remdesivir was given in combination with corticosteroids, and they found some kind of studies found that the remdesivir plus dexamethasone provides some kind of benefit in patients with COVID-19. Also, studies are being going on, trials are being going on, where remdesivir is being studied with other immunomodulators like baricitinib and tocilizumab. Okay, and the results are still awaited. So again, I will stress this point. It is the one approved drug by the FDA for the treatment of COVID-19 in a hospitalized setting. Coming to another upcoming drug, which is still clinical trials are going on, that is molnupiravir. This is an investigation oral small molecule antiviral. This is also a prodrug which is active against our SARS-CoV-2. Okay, so how does this drug work? This is also, as I said, a prodrug, right? So it is when given active triphosphate gets converted to an active form, and it goes and gets incorporated into the viral RNA. Okay, so what happens because of this? They kind of misdirects the viral polymerase to incorporate either guanosine or adenosine during the viral replication. So what is happening because of that? This will lead to accumulation of lot of deleterious errors. Okay, so a lot of errors will be there, and because of that, the virus will become throughout the viral genome, the virus will become non-infectious and is not able to replicate. To tell in a simple form, it interferes with the COVID-19 virus replication process. Okay, so I already told you this is something which is trial is going on. They have done phase 3 trial, double-blind, randomized, placebo-controlled trial is going on to evaluate the efficacy and safety of treatment with molnupiravir. But what they have done in this trial is they started the drug within 5 days after the onset of the signs and symptoms in non-hospitalized, unvaccinated adults with mild to moderate COVID-19. Okay, so they have targeted, the study is just is targeting only unvaccinated adults. Okay, so it is the Merck company. You must have heard of this company. They are the ones who have brought out this particular drug, and the trials are going on. And they have sufficient data. It seems, according to them, that they have sufficient data, and they may ask for emergency use authorization. And once it is available, according to their data, early treatment reduces the risk of hospitalization or death. Okay, so that is one of the upcoming drugs, molnupiravir. Going to another drug, savipiravir. Now this is a purine, that is guanine nucleotide analog, and it was initially developed against influenza. Okay, it was initially developed against influenza, but during the COVID-19, as I said, we didn't have a lot of medications to be used. So it kind of developed, attracted attention because of its large spectrum antiviral properties. Okay, so another thing was the drugs which are kind of resistant, to the other drugs which became, the virus became resistant to them. Here it was more beneficial than those drugs. So how does it act? This also inhibits the virus replication by binding to the RNA-dependent RNA polymerase. But the problem was that it was causing some adverse effects. So definitely, when we give a particular drug, there may be some adverse effects. In this case, again, increased liver transaminase enzymes and prolonged QT interval was seen. So even though the trials showed, like for example, one trial which was done in China, they have shown that there was, that viral clearance time, it happened very fast in treated patients as compared to untreated patients, and also a lot of some other trials also showed data which was promising, which was showing better clinical efficacy in patients who were treated with this particular drug. But because of these particular adverse effects, and also it was causing drug interactions when it was given with other drugs. So presently in our list, in our country, the ICMR list, this particular drug has been dropped, I should say, and it is more like it is available in other countries as a treatment regime for the treatment of COVID-19. So here you have favipiravir. Then coming to the other drugs which are useful which were used in COVID-19 treatment, we have interferons. You all know they are a family of cytokines with in vitro and in vivo antiviral properties. And you also know there are different interferons of that. Like for example, you have interferon beta 1a, which was actually used for the treatment of multiple sclerosis. Then you have interferon alpha, which was useful for treatment of hepatitis B and C virus infections. But when it came to COVID-19, it was interferon alpha and lambda, which underwent certain trials to see whether they are useful or not. So they did go underwent large trials, and they came to certain conclusions because of the trials, because they said that our National Institute of Health it kind of gives certain recommendation based on a lot of the clinical trials which is done world over, and they recommend give certain recommendation based on those trials. Like they came to this recommendation that systemic interferon beta should not be used for the treatment of hospitalized patients with COVID-19. This should not be used. But when it came to interferon alpha or lambda for the treatment of hospitalized patients with COVID-19, can be done only in a clinical trial. Okay. Interferon alpha and lambda for the treatment of patients with COVID-19, except in a clinical trial. Similarly, interferons, recommends against the use of these drugs, except in a clinical trials. Okay, non-hospitalized patients also. So what is the reason why they came to this conclusion? Because the studies, they were not able to demonstrate efficacy for the interferons in the treatment of COVID-19, and also in some trials, they found out that it was causing potential harm in patients with severe diseases, especially in patients who needed high flow oxygen, NIV, that is non-invasive ventilation, or mechanical ventilations. Okay, and also here, when it came to giving it in children, again, they didn't have sufficient data, so they do not recommend it in children. Studies showed that giving them in pregnant women was not causing, did not lead to increase the risk of adverse birth outcomes, but still it is, they have not yet given clear-cut instructions whether it can be given in a pregnant woman or not. Okay. So coming to another fixed dose combination, that is lopinavir and ritonavir. Okay. And also some other HIV protease inhibitors. Now, this particular drug, why this particular drug came into light for the usefulness in COVID-19 is the replication of SARS-CoV-2. We all know it depends upon the cleavage of polyproteins. Okay, into an RNA-dependent RNA polymerase and helicase. You must have learned about it in the previous sessions. Two proteases are responsible for this cleavage. One is the 3-chymotrypsin-like protease, and another is the peptide-like protease. Okay, so this particular group of drug, a fixed dose combination, lopinavir, ritonavir, they are two structurally related protease inhibitors which are given together. So initially they were developed as an inhibitor of the HIV virus, that is human immunodeficiency virus 1. And they were able to arrest its maturation and decrease the infectivity. Okay, so why do we have to give two particular drugs? Because ritonavir, it's always given in a low dose along with lopinavir. Why? Because it is able to inhibit the metabolism of lopinavir. So when it inhibits the metabolism of lopinavir, it improves the antiviral activity of lopinavir. That is the reason why they are given as a fixed dose combination. But again, when you are doing a lot of trials, you collect so many data before you give complete approval for the drug to be used for the patients. Here also, it was showing certain adverse effects like QTc prolongation, hepatotoxicity. It was also showing a lot of drug interactions which was causing toxicities, and also there was a doubt whether this combination will be causing enough drug concentration to inhibit the SARS-CoV-2 virus. Okay, so since the clear-cut, clinical trial data was not available, this particular currently the use of this particular combination and also other HIV protease inhibitors are not recommended for the treatment of COVID-19 hospitalized patients and also in non-hospitalized patients. Okay, now coming to a drug which was came into limelight last month, I should say. Paxlovid is a trade name, and it consists of again a fixed dose combination known as the nirmatrelvir. Okay, along with ritonavir. Okay, the Paxlovid, this is a trademark which was brought up by company Pfizer, and they have come out with this saying that this is the first oral antiviral treatment candidate, and they found their data which they have collected, they have found that this particular combination was able to reduce the risk of hospitalization or death by 89% as compared to placebo in non-hospitalized high-risk adults with COVID-19. Okay, so their data is something they have a promising data, it seems, and they also said in the overall study population through day 28, no deaths were reported in patients who received this particular combination as compared to 10 deaths that happened in patients who received placebo. So this is also a specifically designed protease inhibitors, okay, which as already said is an enzyme that is the virus needs to replicate. Okay, so Pfizer has come out with a new oral antiviral treatment, but it is still going through phase 2, phase 3 studies are going on. Okay, again here ritonavir is the one which is will slow down the metabolism or breakdown of that particular drug. Okay, so that the antiviral activity of this particular drug is increased. According to them, if their results are successful, they can be given at-home treatment. At-home treatment to reduce the illness severity, to reduce the hospitalization, to reduce the death also. And they are saying that they have sufficient good data which is able to act against the newer variants also. So it may be useful in multiple types of coronavirus infections, where we have to wait for their data. Once they have sufficient data, they will ask for emergency use authorization as soon as possible. That is what they are promising us. Paxlovid is a drug which has come into existence last month. Okay. So as I said, we are dealing with drugs which are inhibiting virus. Okay. So in the beginning of our pandemic, we didn't have drugs. So we one of the drugs that was prescribed was chloroquine, hydroxychloroquine with or without azithromycin. We all know that chloroquine is an anti-malarial drug, and hydroxychloroquine is an analog of chloroquine, which is normally prescribed for treating autoimmune diseases like SLE, rheumatoid arthritis, also for the treatment of malaria. We all know this, right? So how was this useful in a virus? It was noticed that both chloroquine and hydroxychloroquine increases the endosomal pH. So increasing the endosomal pH, what will happen? Will inhibit the fusion between the virus and the host cell membrane. Also, it inhibits glycosylation of the cellular angiotensin converting enzyme 2, ACE2 receptor, and this will interfere with the binding of the virus to the cell receptor. Also, they have immunomodulatory effects. Okay, because of all these things, this particular drug had some amount of effectiveness in controlling the viral infection. Okay, and also there is another antibiotic, that is azithromycin. We all know it is a macrolide antibiotic which has got antiviral and anti-inflammatory properties. Its studies have been done for its effectiveness, where they checked it, activity against the Zika virus, Ebola virus, and all, and also some severe respiratory tract infections and all. But this particular in studies, they saw that when hydroxychloroquine, azithromycin, when they were given in combination, yes, they had synergistic effect, but that was not enough to control the upper and lower respiratory tract viral loads. And another issue was that they were causing cardiac adverse effects like QTC prolongation, points, and ventricular arrhythmias, cardiac death. Here, azithromycin is also causing QTC prolongation. So definitely, the combination has to be avoided in patients. Another thing was that the chloroquine, hydrochloroquine, hydroxychloroquine were able to inhibit the cytochrome P450 to B6. So it was when it is given with along with remdesivir, it was able to decrease the antiviral activity of this particular drug. So giving in combination with remdesivir, this was not also recommended. So what is the current status of this particular drug? Currently, the use of chloroquine and hydroxychloroquine with or without azithromycin is not recommended for the treatment of COVID-19 in hospitalized and non-hospitalized patients. Coming to another drug which was in news, that is ivermectin. We all know it is an anti-parasitic drug which is used to treat tropical diseases like onchocerciasis, helminthiasis, and scabies. And also, study was done because of its broad spectrum activity in vitro. Studies were done its effectiveness to see against again Zika virus, dengue, even HIV and yellow fever. Okay. So how was it found useful in COVID? This particular drug, it was seen that in the in vitro studies suggest that they act by inhibiting the host importin alpha beta 1 nuclear transport proteins. So with this particular transport protein, it's a intracellular transport process, which kind of the virus will use this particular protein to increase the infection by suppressing the host antiviral responses. Okay. So this came into light because of the usefulness by this particular mechanism, and it also was able to interfere with the attachment of the SARS-CoV-2 spike protein to the human cell membrane, and it also has some anti-inflammatory properties which they found to be beneficial in controlling the infection in COVID-19. But when studies were being done, not much studies were able to find out whether it shows any benefits or it was worsening the disease. Not that much of data was able to collect, but some studies were showing they were able to reduce the inflammatory markers, they were able to, little time the viral clearance was happening, lower mortality rates in patients who received ivermectin than in patients who got comparator drugs or a placebo. Okay. So because of insufficient evidence, presently the use, the recommendation is neither they're not telling either for or against the use of ivermectin for the treatment. One study was of concern because it was telling that the plasma concentration necessary for the antiviral efficacy needed 100-fold. The dose needed to produce that particular efficacy needed a dose which was a lot higher than the one that is usually prescribed in the humans. So keeping these things because of the insufficient evidence, presently recommendation is not for or against the use of ivermectin for the treatment of COVID-19. What they are trying to suggest is we need to do well-designed, we need to do well-conducted clinical trials, like more information for it to be prescribed for COVID-19 patients. Then you have nitazoxanide. This is also a drug which is useful. It's a broad spectrum hyaluronan anti-parasitic drug, which was useful for the treatment of cryptosporidium and giardia duodenalis infections. And this is also, when it is given, gets converted to its active metabolite, and it is also known to have antiviral activity, and the studies are being done to see its effect against influenza viruses, hepatitis B and C viruses, Ebola virus, rotavirus, and also the MERS-CoV and SARS-CoV-2. All these studies are going on. So how did this particular drug was beneficial? It was able to inhibit host enzymes, which impairs the post-translational processing of viral proteins and also has inhibitory effects on pro-inflammatory cytokines. So this particular drug also came into one of the drugs which was suggested for treatment of COVID-19 treatment guidelines. But again, we have not much of evidence was able to be generated. There was certain studies which was done in Brazil and United States, and they were not able to give, even though the treatment was started within 2 to 5 days after the illness onset, but not sufficient evidence was there. So again, we need to conduct more clinical trials for this particular drug to be useful in the treatment of COVID-19. And also another thing you can see here, it was causing certain drug interaction. So this is also one such drug which also still needs more data to be recommended for the use. So what I have been trying to tell you is the drugs which is showing antiviral property, that is, it is able to control the virus replications, that has been useful in COVID-19, which was some of them are repurposed drugs, some of them are new drugs which has come into existence. So particularly presently, remdesivir is the only antiviral drug that is approved by the FDA for the treatment of COVID-19. There are other therapies also which you all must have come, because my topic is limited to one particular area. So I thought, just to conclusion's sake, I will just tell you a few things about the other therapies which is under evaluation, which is recommended under evaluation for the treatment of COVID-19, like anti-SARS-CoV-2 antibody, monoclonal antibody products. So these are drugs which targets the spike protein, and some amount of clinical benefit has been noticed and is useful in treatment of non-hospitalized patients with mild to moderate COVID-19. And one such drug is casirivimab, which is usually given along with another monoclonal antibody, that is imdevimab. Okay, so it is given as an IV infusion or as a subcutaneous injections. Then plasma therapy, we all have heard about it. So the thing is that the plasma from the donors who recovered from COVID-19 may contain antibodies to SARS-CoV-2, which help in suppressing the viral replication. But the current guidelines is that they are not recommending this particular, because of insufficient evidence, not recommending the use of COVID-19 convalescent plasma therapy for treatment of COVID-19 patients, hospitalized patients with or without impaired humoral immunity. Okay, so without sufficient evidence, we cannot recommend it. Okay. Then you have immunoglobulins, SARS-CoV-2 specific immunoglobulins. Now here also concentrated antibody preparations were derived from pooled plasma collected from individuals who have recovered from COVID-19. Okay, and they found that it was able to suppress the virus and modify the inflammatory response. But again, here insufficient evidence. So this is also they're not recommending either or for or against the treatment for SARS-CoV-2. Okay. Under evaluation, another therapy is a cell-based therapy. Cell-based therapy, that is stem cell therapy. We all know mesenchymal stem cells. They are usually a lot of studies are going on to know about the immunomodulatory properties. Okay. Why this came into here? Why they are evaluating here? Because in the hypothesis is that the mesenchymal stem cells could reduce acute lung injury and inhibit cell-mediated inflammatory response, which is induced by SARS-CoV-2. Okay. Another thing, that this particular stem cells, they do not have angiotensin converting enzyme 2 receptor. Now this is the receptor which the virus will bind to and enters into the cells, right? So they are saying cell-based therapy, these will be resistant to infection, especially the SARS-CoV-2, and they may be beneficial. But the clinical trials are still going on till it is confirmed. It cannot be recommended for treatment. Okay. You also have heard of immunomodulators. A lot of immunomodulators were under trial. One such was corticosteroids. A lot of studies has been done. Multiple randomized trials which indicates that the systemic corticosteroid therapy improves clinical outcomes and reduces mortality in hospitalized patients who require supplemental oxygen, okay, because they are able to mitigate the COVID-19 induced systemic inflammatory response. But they also have observed no benefit of seen in systemic corticosteroids in hospitalized patients who do not require supplemental oxygen. So it was more beneficial for patients who require supplemental oxygen. So this is one which I have taken from the current guidelines for COVID treatment, and they have given these recommendations based on the disease severity. What they have said is hospitalized but does not require supplemental oxygen. You can give, the panel recommends against the use of dexamethasone or other corticosteroids. Then you have hospitalized and requires a supplemental oxygen. Yes, you can use one of these. One is remdesivir, or you have dexamethasone plus remdesivir or dexamethasone. Then you have hospitalized and requires oxygen to high flow device or mechanical NIV. So you can use one of these, again dexamethasone plus remdesivir, and hospitalized and requires mechanical ventilation or ECMO. Here also, for patients who are within 24 hours of admission to the ICU, dexamethasone plus IV tocilizumab. Okay, so this is the recommendation given by the current guidelines of NIH. So Omicron, yes, we have been talking about it since morning. Our government guidelines, according to the government guidelines, the treatment protocol for COVID-19 caused due to Omicron variant is essentially presently it is same only. What they are saying is the variant, since the variant is new, they are kind of managing the cases to be managed in separate isolation facilities so that the transmission is controlled. But the same treatment protocol has to be followed. ICMR always updates treatment protocols in COVID-19 patients. They have a treatment protocol for mild disease, moderate disease, and severe disease. But they also make it very clear that in case of certain use of certain drugs based on limited available evidence, only in specific circumstances it has to be used. That's what they very clearly say, whether it is remdesivir use or tocilizumab. For example, remdesivir, it is considered only in patients with moderate to severe disease who require supplemental oxygen. There should not be any renal and hepatic dysfunction. You can give the drug only within 10 days of onset of symptoms. And similarly for tocilizumab also, it has to be certain considerations has to be kept in mind when you are prescribing this particular drug, like presence of severe disease that is within 24 to 48 hours. Significantly raised inflammatory markers should be there, not improving despite of use of steroids, no active bacterial, fungal, and tubercle infection. So these are certain guidelines which is being given for the management of COVID-19. So these are my references.
Okay, girls, I'm starting. Thank you, Dr. Geeta. That was a very elaborate and complete session for us on the entire range of options available in the context of COVID-19 as well as Omicron. To rephrase your own words, in the context of emerging variant of concern Omicron, the treatment guidelines and the options as you have elaborated, the guidelines specify that the options essentially remain the same. And the penultimate slide in which you have drawn our attention to the current treatment guidelines, where the classification says hospitalization requiring oxygen therapy, the hospitalization not requiring oxygen therapy, and the grades of severity of the hospitalized patients. The guidelines are very clear. Thank you so much for that very informative and complete session about Omicron, as well as the COVID-19 and various, though the session is titled Oral Antiviral Drug Options, you have taken extra efforts to enlighten us about the entire range of options available under the heading of pharmaceuticals. We once again thank you for your elaborate session, because this looks like we are prepared when we read our articles and scientific literature, what are all the options available. And I'm sure my interns and postgraduates, as well as the young faculty in the department, including myself, are given a very good lecture and informative session on this. Thank you so much once again for your efforts as well as time taken to prepare this session. Thank you so much.
Thank you, Dr. Sucharita. I again would like to thank you for giving me this opportunity. Thanks a lot.
Thank you. So, dear participants, we will move on to the next session, taking into consideration the time concerns. So the next session as per the scheduled event is Universal Health Coverage, COVID-19 vaccine and Omicron. That is supposed to be taken by me. So I'll jump on to my session. I will request Kannan sir to alert me whether I'm able to pull out my presentation. Is my session visible?
No, the screen is not shared.
Okay, sir. That's exactly what I wanted to. Share screen. Now?
Yes. Now it's shared.
Yes. You always have to teach me, sir. I'm forever. Thank you so much. So we'll go on straight to the session. Universal health coverage, COVID-19 vaccine and Omicron. Again, these are my affiliations: Tagore Medical College, Central Research Lab, and the new initiative Center for Integrated Oral Cancer Prevention Research Network. So, drawing your attention to the title topic, Universal Health Coverage. Recently, on December 12th, 2021, we have observed the International Universal Health Coverage Day. On the day, we also conducted a training for our interns, both medical and dental interns, posted on community medicine and public health dentistry about health counseling, especially targeting on tobacco behaviors. So that is an opportunity for us to enhance their skill set. And coming to this particular International Universal Health Coverage Day, this year the theme is Leave No One's Health Behind and Invest in Health Systems for All. So connecting this particular universal health coverage theme to COVID-19 vaccines and Omicron, from the morning we have been talking about the World Health Organization labeling Omicron as variant of concern on November 26th. And as of December 16, 2021, 5,563 Omicron genome sequences from 60 countries have been uploaded to global initiative on sequencing aid. And I would like to discuss this slide a little bit so that the entirety of emergence of Omicron in the background of COVID-19 will be very clear to us. There was this Christmas party which was organized in Oslo. And in Oslo, Norway and Denmark, that particular part of Europe, they celebrate Christmas very early. So on November 26th, in a restaurant in Oslo, 111 persons attended this Christmas party. All of them were aged between 13 to 50 years, and all of them have been vaccinated, most of them. 70% of the attendees subsequently were diagnosed with SARS-CoV-2, and most of them with Omicron variant. And more than 60 people who visited the restaurant, unrelated to this party, who visited the restaurant on the same evening, have also been confirmed as infected. And all infected at the party, they reported a negative RT-PCR test 1 to 3 days before the party. And all of them started developing the symptoms 3 days after attending the party or the restaurant. And over 70% reported cough, lethargy, headache, sore throat, and half of them reported a fever. Last point is important: no hospitalizations occur. So this captures the entirety, because we are heading to a party season, whether it is Christmas, birthdays, get-togethers, New Year parties, all of us want to wind up the entire year and do this kind of events. But unfortunately, this should be a wake-up call. Please remember, though all of us are vaccinated with two doses of vaccination, being healthcare providers, we should remember this Christmas party in Oslo. Though we think we have a negative recent test report, we should be aware that this will not prevent us from getting a new variant entering into our body or helping us get infected. Breakthrough infections are the norm with Omicron variant. So please remember this. And looking at the data coming in household transmissions for Omicron variant, if you look at this data, in household settings, Omicron is infecting roughly 2 to 3 times as many people as Delta. That's why household transmissions are a red alert. As Dr. Vikram has highlighted in his presentation, isolation of the cases identified in a household setting, quarantining them, helping them complete the entire duration of quarantine is important. Contact tracing of the people who come in contact with these cases is extremely important. We have to be vigilant and we have to be in the mode of preparedness for this kind of setting. And if you look at the UK, as I have highlighted in the morning, UK is in red alert. Globally, Germany and other countries have stopped traveling from UK into their countries, and they have stopped international travel of flights from UK into their countries. Also, UK has been highlighted as major incident, as I have discussed in the morning. As you have seen this curve, doubling time R is 3.7. So we have to be extremely careful. UK is emerging as the next epicenter. And if you look at this particular slide, neutralization of authentic virus with vaccine induced as well as convalescent sera, which Dr. Geeta just now concluded in her presentation. The varieties of vaccines A, B, C, D, as well as the convalescent sera in the bottom half of the slide show that for the red slide, red point of Omicron variant, absolutely no antibody response was elicited, or minimal antibody response was elicited with Chad-Ox vaccine and BioNTech vaccine in the C and D variants. But if you look at the convalescent sera also, absolutely, that's why we say like we have to be looking at the emerging data and science in the context of Omicron variant. And this last H category of super immune, that is the only category of individuals who elicited antibody response to this Omicron variant. And who are these super immune individuals? These are the people who are infected naturally with COVID infection. Later, they received their vaccines. These are the category of individuals named as super immune. These are the only individuals who elicited antibody response, who developed antibody response to Omicron variant. These are the category of individuals termed in the literature as super immune. So please understand that though you are having a natural infection with COVID, you have to follow it up with COVID vaccinations. Please, this is a message from this slide. And the data coming from Pfizer vaccine for Delta and Pfizer vaccine for Omicron, as you can see, after second dose post 5 months, this is the immune response for Delta variant, whereas this is the 3rd week later Omicron response. So it is slowly building up. And if you look at the BioNTech 3 doses later, what is the immune response? As you can see, Omicron variant is in purple. And after second dose, 21 days after second dose, the immune response is slowly building up. But 1 month after the 3rd dose, you can see good immune response for the purple block of Omicron variant. This is for BioNTech. Another study which also shows 3rd dose of Moderna vaccine improves antibody response to Omicron compared to the 2 weeks post dose 2. 2 weeks post dose 3, you can see incremental improvements. So coming to the vaccine efficacy and Omicron, English data, that means data from United Kingdom, shows substantially increased risk of breakthrough infections with Omicron. So that is what we have to be careful. Though we are all received 2 doses of Covishield Covaxin in our country, there is substantial increased risk of breakthrough infections when Omicron is circulating in our population. But the data from UK shows that booster doses push the risk back down to Delta levels. This waves of graph shows that. That is why currently in United Kingdom, major vaccination for booster doses is happening. 1 million doses are being delivered on a daily basis. Entire population are requested to get this booster shots. When I say booster, that is a 3rd dose. And if you look at this slide, which shows empirical estimates of infection and reinfection hazards across wave 1, 2, 3, you can see that it shows that in compared to wave 2, right now we are in wave 3. So the reinfection rates are slowly on the rise. So that is where Omicron is making an entry slowly from November onwards. So we have to be understanding that with mass vaccinations picking up from 60% globally, US has 60%, UK has 60%, India also is aiming for 60% and above. Wave 3 will only be on the rise unless mass vaccinations, and Omicron variant, as I have shown previously, it is not offering protection with just 2 doses. We have to boost it up. Coming to the next one, Dr. Geeta has alluded to it, monoclonal antibodies. Of all the range of monoclonal antibodies currently under trials and various data inflowing, Sotrovimab, this is the only monoclonal antibody which emerged as the real winner with this kind of antibody response. Apart from that, all other antibodies showed a poor show. So we have to be careful when we are talking about monoclonal antibodies. She has summarized in her slide the range of options. So this is the story with monoclonal antibodies. So to summarize, vaccines, monoclonals, antivirals. If you look at vaccines, decreased neutralization from prior vaccinations and prior infection with only 2 doses. There is decreased effect and waning effect, so we need to boost it up. That is what we are talking from morning. At least boost a dose for high risk group populations like healthcare providers with repeated exposure to patient populations and infected cases. Expect these vaccines to remain effective against severe illness and death. That is most important. We have to re-emphasize the message in the community setting and hospital setting. Whenever patients are asking this doubt, we have received 2 doses. Are we at risk of getting, are we at risk of severe illness and death? We have to emphasize that they remain effective against severe illness and death, but not against reinfection with Omicron variant. Boosters, as the data shows, third booster dose is amplifying the antibody response. Coming to monoclonals, except for Sotrovimab, the FDA authorized, the other available monoclonals have little activity against Omicron. And coming to antivirals, Dr. Geeta has addressed this adequately, elaborately. So except for Remdesivir and Molnupiravir and Paxlovid, these are the drugs governments are stocking up in case of preparedness kind of mode. As expected, February is the wave peaking in India. As per the prediction models from scientists, we should be also stocking up all these drugs. And according to the guidelines, we have to use them judiciously with the discretion from the clinicians according to the classification. Madam has shown us people requiring oxygen therapy, not requiring hospital therapy, oxygen therapy, hospitalization. We need to be judicious. Otherwise, like in wave 2, we will be running into shortages and desperation. We should avoid that. So coming to what do we need to do? Get vaccinated. If someone is not yet vaccinated, even first dose, please get vaccinated. If you are due for second dose, get it done. If someone needs to get the boosted dose, at least in developed world, UK, US, everyone is getting boosted doses. But in India, we need to wait for our government guidelines, Ministry of Health and Family Welfare. As morning, Dr. Kulandaswamy sir has highlighted, negotiations are going down. Policymakers will definitely come out with a plan, at least for healthcare providers, because most of us has completed our second dose in March, and we are due for at least a booster dose because of this variant in circulation. Get prepared mentally to act more cautiously in Omicron proves to be more infectious, immunoevasive or both. We have discussed elaborately. Follow the news and science, because authentic sources of information are very important. Dr. Vikram highlighted it. What are those sources of information for us? Ministry of Health and Family Welfare, Tamil Nadu government sources. They are updating as per the data emerging. So we need to look into the context. Though I'm presenting you data from US and UK with variety of vaccines, the data is coming from them, but we need to look regionally, locally. Okay, so we need to look into those sources. And CDC has updated its guidelines. So shortly, I hope our government will also update the booster guidelines for healthcare providers. So to summarize the Omicron, the transmission spread, the vaccine effectiveness, severity, virulence, immune escape, reinfection rates, we have summarized that adequately. So please keep on updating your knowledge. Coming to India data, coronavirus, Omicron, as I said, the live updates are keep on coming in real time. Let us keep tracking that. And as per, as I said, as it is peaking around Jan, February, as per the prediction models and data analytics, the status of these 3 drugs in India, we are stocking up. The government is ensuring that enough stocks are available to target our health system. Coming to the vaccination status, as of today, the website says, yesterday, last night, I have taken this data. We are increasing. As you can see, upward arrows shows that more and more people are coming forward with Omicron scare, and more information about Omicron being circulating, that more and more people are coming forward. We need to enhance those efforts, community engagement. As we discussed, Dr. Vikram's infographics will help us spread the message more widely. Coming to India, total doses given 137 crores. People fully vaccinated means 2 doses, either with Covishield or Covax. This many crores. And fully vaccinated, as I said, only around 40%. We need to amplify that to build up the herd immunity and also the protection among the people. Even if they are reinfected with the new variant of concern, the severity and hospitalization rates will come down, thereby reducing the burden on the health system. Coming to Tamil Nadu, 88.59% of city's population are vaccinated with first dose. So please remember, 2 doses are essential. And even with those 2 doses, there is no protection against Omicron. So please spread the message, amplify the message, get the people to complete the 2 doses. The vaccination centers are rolled out, mega vaccination campaigns everywhere they are happening in Kanchipuram district. Please spread the message. Let us spend a minute before we proceed towards the conclusion. Understanding COVID-19 vaccine hesitancy. This is a study which is focused on low and middle income countries, especially India. When they looked into this, why the reluctance of people to receive safe and recommended available vaccines? That is the definition for vaccine hesitancy. Though in the context of COVID-19, we cannot absolutely quantify about the safety principle because we are using emergency use authorization wherever possible to contain the pandemic. So people's apprehension are well placed about the safety, but we have to emphasize on the technology. The technology is not new. All the vaccine technologies which are being employed for COVID-19 vaccines have been in vogue for 2 decades because of HIV vaccines. All the technologies, whether you take mRNA, vector-driven vaccines, every technology has been in practice in the labs because of HIV vaccine for more than 2 decades, but they are being repurposed for the sake of COVID-19 pandemic. So we have to educate the public. Though it is used in the context of COVID-19 as a novel tool, the technology is not novel. So we have to educate them so that the vaccine hesitancy is adequately addressed. A framework developed for research in high-income countries called 5C model of drivers of vaccine hesitancy. This is the entire model. I have done research why people are hesitating among sexual and gender minorities. This is a model we have employed and tried to interview them. What are these 5C models for vaccine hesitancy? Lack of confidence, complacency, convenience. They are looking for convenience of excuses, risk calculation, and collective responsibility. If you employ this 5C model of drivers of vaccine hesitancy, we can target all these population groups, whether rural, urban, educated, uneducated, vulnerable population, and target them with specific educational messages, behavior modification messages, and promote the uptake of vaccines. And in that particular study, which I have showed 1 or 2 slides before, they try to understand what are the factors in middle and low income countries like India, Nepal, Nigeria, and Pakistan. Why is there vaccine hesitancy in the context of COVID-19, the data shows that vaccine acceptance is explained mainly by interest in personal protection. If people are more interested against personal protection from COVID-19, they are coming forward, whereas concerns about side effects is the most common reason for hesitancy. Okay, so if I'm more concerned about my personal safety, I'm coming forward and accepting. Whether if I'm concerned more about experiencing side effects due to receiving these vaccines, I'm hesitating. And what is the solution here? Health workers are the most trusted sources of guidance about vaccines. So our role here is clearly spelled out. So I implore all my young faculty in the department, my PGs, my interns in the community, please go and do this job. We are the messengers of right message. We have to take this message to the community. We have to remove the factors of vaccine hesitancy. Then only this vaccine coverage will improve. Then only we can target this variant of concern, Omicron, and improve the community's immunity, as well as target them with specific messages so that their concerns will be addressed. So that is my session today. I'm not going to elaborate you more on this because we have discussed from morning in depth. So I'm stopping sharing and I'll invite a couple of questions before we move on to the concluding part of the webinar. Any questions from my department or my interns or anyone participating in the webinar? I'm ready to address them. Thank you so much for this opportunity. So it looks like a silent interaction for me, but I would like to reiterate the message. Vaccination is important here today, and looking at the data, we have a lot of work to do. So without wasting much time, because time is of irreversible resource, I would like to invite the youngest faculty in the department, Dr. Avinash Deepak. Are you online, Avinash?
Yes, ma'am.
Yes, please. So let us proceed with the recap of the webinar. I'm sure you are taking very diligent notes from the morning. So recap the webinar from the morning so that we can move towards the conclusion of the webinar. Thank you so much. Before you proceed, I would like to introduce Dr. Avinash Deepak. He's a postgraduate passing out from Chettinad Research and Medical Institution. As I keep on repeating, but most of you may not be aware, he's the youngest member, but he's very dynamic, dashing, as well as energetic addition to the team of community medicine in the department. And he's always spot on. You allot him anything, he's ready to deliver that, and you will see that delivering that particular activity right now today. We welcome you for doing this recap of the webinar, as well as proposing vote of thanks, Dr. Avinash.
Thank you. Welcome you all. Good afternoon, and once again welcome you all to this webinar on the overview on Omicron and oral antivirals. Today was an amazing session. And today's session, in the beginning, there was an introductory section, which was chaired by Dr. Shri Sucharita and Dr. Kannan Ayanar and Dr. Vikram. They discussed the importance of vaccination amid this Omicron surge and the relevance of the vaccination during this Omicron surge. And this session was followed by Dr. Kurande Sami, former Director of Public Health, Tamil Nadu, and a very prominent public health expert. And he discussed on the Omicron and the public health response. His lecture mostly elaborated as on highlighted the importance of wearing masks in workplaces and public places. And he also elaborated on indoor ventilation and its key factors and its key ideas in promoting COVID-19, preventing the COVID-19 infections. He also spoke about the advocacy for booster vaccine for all eligible populations, mainly the older people and the healthcare workers, and high priority risk groups. And then this overview was followed. I mean, this amazing lecture was followed by a lecture of Dr. Kannan, officer in charge of Central Research Lab. He actually enlightened us on the SARS-CoV-2 variants, the variant of interest and the variant of concerns. And then there was a session on different about the different nomenclatures and how it is how the nomenclature is based on. And he actually enlightened us on the Pango lineage, which names the current variant as B.1.529. And then WHO nomenclature, which names it Omicron, and the next strain clad nomenclature, which names it 21K. And the effect of mutation of these COVID-19 viruses and their influence on the diagnosis and immune. And there was a very nice thing about the immune escape, the concept of immune escape. And then this was followed by a session by Dr. Sucharita, and she provided us an update of the Omicron pandemic which is happening right now, and then the update of the Indian version of the Omicron, update on the Indian version. And she gave us a clear timeline of events from the earliest documented case of the Omicron till the present state, and designation of the variant of concern by the WHO. And then she explained the characteristics of Omicron in comparison to the Delta variant. That is the comparison between the Delta variant and the Omicron based on its treatment modalities and its diagnosis and other things. And then about the growth advantage of the Omicron, then increase the transmissibility and the immune evasion. Like from her lecture, we found out that was the humoral immunity was totally evasive in this case, and the concept of cell-mediated immunology, cell-mediated immunity is still it's still not clear. And then she also informed us about the diagnostic kits developed by the ICMR, and also about the IIT Delhi kit developed by Omicron kit developed by IIT Delhi, which gives you a result in 90 minutes. And then about the international and national burden of the disease. She also elaborated on the international and the national burden of the disease, and about travel restrictions that is been employed. With that, her session ended, and we then came to the session delivered by Dr. Vikram. He's the assistant professor in the Department of Community Medicine, and he discussed on the protocol for travelers during immigration. And then along with that, he also discussed on the Omicron public health surveillance and how to protect yourself.
I guess there are some network issues. Can someone check and get back from Dr. Avinash side? So Dr. Avinash was mentioning about Dr. Vikram's session, in which he talked about public health surveillance tools, especially the travel surveillance at airports, seaports and land ports, as well as the various measures. Yeah, he's back.
Yes, ma'am. Actually, there was some technical difficulty, ma'am.
Please proceed, doctor.
Then coming back to the lecture of Dr. Vikram, he also enlightened us on the initiatives of the Tamil Nadu government and use of thermotag path kits for the diagnosis of the new Omicron variant. He also discussed on the protocol for travelers during immigration and better and effective screening tools for people that are entering the country, so that they can be monitored, the infection can be monitored then and there. And then he also talked about participation of the NGOs, community leaders, and civic and social authorities and their role to improve the diagnostic and control of the Omicron variant. And then he also talked about genomic sequencing of the affected to find the Omicron cases. as the S gene target failure is the criteria for diagnosis of the Omicron variant. This can be used. And he also talked about newer initiatives by the state and the central governments, and then and also other ways like prevention of discrimination, which will lead to better diagnostic rates, and then points to boost the morale of all the healthcare workers, which will also lead to an effective disease control among the nation, people of the nation. And then he also spoke about helplines, various helplines like the 1075 helpline for information on COVID and other emergencies, and also psychosocial support such as helpline for suicide prevention and such things. After this session, we had a session by Dr. After we broke for the lunch, and then we had a session by Dr. Dr. Geeta, Professor and HOD of the Department of Pharmacology, on oral antivirals. And coming to her session, the session was very elaborate, and she gave us various treatment guidelines and protocols. And also she elaborated on various antiviral drugs and their mechanism of action, and also their adverse effects. She spoke about the drug remdesivir, which was approved by the FDA for the treatment, and also its adverse effects. And she also talked about adaptive COVID-19 treatment trials, and also its placebo and also certain RCT trials based on placebo and the adaptive trials for remdesivir. And then coming to other drugs, she elaborated details about other drugs such as molnupiravir, favipiravir, and then interferon therapy for Omicron variant and COVID-19 in general. And then she also spoke about the NIH recommendations of interferons interferons which are contraindicated for the COVID-19 treatment. And then coming to the protease inhibitors like loviparin and ritonavir and nirmatrelvir. She also spoke about the effects and adverse effects of such drugs and their relevance in the treatment in the present pandemic. She also spoke about chloroquine, hydrochloroquine, and azithromycin and their efficacy and their recommendations. She spoke about drug interactions with, and she also spoke about the drug interactions of chloroquine with remdesivir, and then with ivermectin and its beneficiary effect in COVID-19 treatment of COVID-19 patients, and also its anti-inflammatory effects and its effectiveness. Then just a second. And also she also spoke about the recommended therapies that is being recommended by the FDA and WHO, which were remdesivir therapy, then the anti-SARS-CoV-2 antibodies, then convalescent plasma therapy, and then immunoglobulins, supplementation of immunoglobulins such as specific SARS-CoV-2 immunoglobulins, and then cell-based therapies, and then corticosteroids, the role of corticosteroids in the treatment of the COVID-19 pandemic situation. Then coming to the final session of the day, which was delivered by Dr. Sri Sucharita ma'am, Professor and HOD Department of Community Medicine. She spoke on the COVID-19 vaccine and the newer vaccines for the Omicron. And she also gave us a nice story about the Christmas party that happened in Oslo, Norway. And then she talked about the household transmission of the Omicron virus, and then a neutralization of the virus with the and the neutralization of the virus by the vaccine. She discussed many scientific research studies which told us the efficacy of certain vaccines like the Pfizer vaccine on Delta and Omicron strains, and the immune response based on the number of doses. We also found out that with the number of doses and increased booster dose, the efficacy increases and the risk of the disease and its severity decreases, which was very clear with all her research slides and infographics. And then coming to the monoclonal antibodies, it was also found that the monoclonal antibodies had a good neutralizing effect on the COVID-19 variants. Now coming to the last few minutes of her detailed lecture, she talked about the efficacy of the comparison between the efficacy of monoclonal antibodies, vaccines, and antiviral drugs, which was found that there was good neutralization when in case of booster doses, and in case of monoclonal antibodies, the only thing that was effective was sotravimab, and then antivirals. The FDA has said that there is not many antivirals that are very effective during this pandemic and not very relevant. And now coming to the total number of vaccinated people, it was from a lecture. It was quite evident that there was India could catch up 137 crore people, and it delivered doses of 137 crore vaccines, and 54.6 crore people were vaccinated, which was 39.5%. And she also explained this on the 5C model. So now with this, we have come to the very informative and elaborate lecture and webinar on the Omicron. And I thank all the esteemed speakers, who put out the time and gave us a very clear understanding of all the relevant and irrelevant things during this pandemic, and guided us in a very amazing way, and helped us to understand the basic of helping people out and helping us to come out of this pandemic. And I propose my thanks to Dr. Kurandeswamy, former DPH of Government of Tamil Nadu and a public health expert, and our dear HOD, Dr. Sri Sucharita, and Dr. Kannan, officer in charge of Central Research Lab, Dr. Geeta, professor and HOD of the Department of Pharmacology, and Dr. Vikram, assistant professor, Department of Community Medicine, for their elaborate, amazing, and very informative lectures. And I pray to the God Almighty that this Omicron crisis or this pandemic gets over very soon. And thank you all for your honorable support. And I also thank all the participants for their amazing participation. And with this, I end my vote of thanks and summary, and I hand over it to Dr. Sucharita ma'am for her vote of thanks. Thank you.
Yeah. Thank you, Dr. Avinash. That was a wonderful summarization of the entire day. Though we had time to prepare our sessions, your participation from the morning has definitely helped us that we have done our job, because you have done such a great, tremendous job in summarizing. I would like everyone to acknowledge the great efforts you have taken from morning to summarize such crisp and wonderful summary. Thank you so much. Your participation has brought a smile on my face, because it's not easy to put together such a CME itself, because it is still emerging. The thing is emerging. The variant of concern is emerging. As speakers, it was challenging for us, but for you to summarize such crisp summary, it's wonderful. Again, thank you. And again, on behalf of Department of Community Medicine, Central Research Lab, and Department of Pharmacology, we thank one and all who joined us today in this academic journey and scientific update. And we thank our Professor Dr. Mala Madam, the beloved chairperson of Tagore Educational Trust, for giving us this wonderful avenue to discuss these scientific updates. Our sincere thanks to Secretary, Tagore Educational Trust, Mr. Manikantan sir, for his constant support. And though Dean Madam and MS sir, Dr. Kumuda Lingaraj, Dr. Karunanidhi sir are heavily involved in administrative dealings of the institution, we value their continued support, and we thank them for this encouragement to conduct these scientific events on a regular basis. And I thank all the participants for being with us in this journey, and we look forward to share more updates as and when required. Thank you one and all. We are signing off. Thank you so much.
Thank you, ma'am.